and his entire team for collaborating with Binghamton University and bringing one after the other. Previously, the dean of that university has come. Now, ma'am has come, and all this is only to really create an environment wherein our students get good number of opportunities to really go over there and work there. Our faculty can exchange their research with the institutes. So with all these motives behind it, the whatever the engagement sir is taking care is really something amazing. And coming to, because of that Viper only, we also at our institute we could have some specific courses wherein basically we are standing apart from all the other engineering institutions. The biomedical engineering of BVRIT in Narsapur was, of course, since inception, the brainchild of our founder chairman, where he can visualize the future of that. And all these years, the faculty of biomedical engineering has taken it forward in BVRIT in Narsapur, madam. And the real essence of that, after 25 years, we could see the practical outcome of those students outside. Apart from that, good number of our biomedical engineering students have settled abroad in US, especially after their MS there, and they are in very good positions there. And that is the mindset which this branch was started in 1997, when no other institute here is having such type of branch. Apart from that, our present chairman Sri Vishnuraj Gari vision actually having a branch like pharmaceutical engineering in our institution, and thinking that the pharmacy institution is there with us, and collaborating this essence of these two, especially the pharmacy plus our own chemical engineering, again our founder chairman's brainchild at 1997. So conglomeration of these two put together, now exactly the practical application of those two put together, that is the need of the hour, which we could see wherein Hyderabad becoming a pharma hub actually for the entire this country basically. So that's the mindset and vision with which the management has brought in the various courses into life. Same again, our sister institution Ramesh Garu has talked about his own basic institutions, but having such an institution by the side of us, we are able to really get that inspiration, get the juice of it, and flourish in a different way compared to any other engineering institution in this part of South India. That's the beauty of these two branches here, and they are doing extremely well, and we are attracting the best students to those two branches here, apart from that any conventional engineering college. So this is first thing. And having you here, and our students and faculty are also here today participating in this workshop along with the young buds of the Viper here. And I'm sure that with your basically what you call it as intensive talk today, and yesterday also you interacted with us, and again the faculty is going to interact, we are sure that the outcomes of yesterday and today's thing definitely will yield in some type of what we call it as understanding in taking this relation forward actually, with a view that both the students and faculty get benefited. Thank you very much for giving me this opportunity. Thank you all. Thank you. Thank you, Ramesh Garu. Thank you so much.
Thank you, sir, for your lucid words. Now I request our principal, sir, to address the gathering.
Good morning. Good morning. Thank you. I think still the voice is not energetic. But anyway, I think I understand a little startup is needed, and that energy will be provided by our guests, right? So I think we have with us Professor Karan Beth, who is one of the very leading pharmacists in the globe. And I think she's an active member of FIP, which I think I will be sharing it during our discussions. And again, this year she is going to Cape Town, right? And I think she is one where we can learn from her. And I think me going along with her right from, I think, not even 24 hours, right? The energy she has is really outstanding. I think I would like to share that your smile is infectious, right? And she keeps on sharing whatever is there. And the way she is interested towards development of the pharmacy profession, right? And the way she is taking it forward is really awesome. And you will be surprised. I think one important other thing is, I think her energy levels to showcase her. She, I mean, we should not share it on the stage, but she has a very, active grandson who is still very active, and still she's quite active along with him. So I think that's what we all got shocked by her energies. She had very less sleep right from Ahmedabad, but still she is actively participating, running with us, and actively one way preparing her PPTs to meet our needs, and one way she is ensuring to provide us the energy. So I think this very humble beginning. We are very happy to have you here. And I think the entire team of Binghamton, we started a couple of years ago. And now slowly the crystallization of it is happening. And we are going to yield the products shortly. And the stepping stone was done in engineering. Slowly it got percolated to pharmacy. And your dean has been here. Now you are here. Later on, I wish you're going to bring your other colleagues also to share your practice sessions with us. And we'll also be going and coming to you, as you promised that you will take me for a dinner to your house. Definitely, I think we will have it shortly, I believe, right? So I think with this, I just don't want to boast much, but I wish every one of us should take her as a role model, and I think that will be definitely useful for us. And I requested her to compare the practice happening abroad versus India, right? And how careful they are with the community. Their motto is very simple: serve the community. But I think that is slightly lacking in our Indian system, right? Whatever they do, they want it crystal clear, more precise. I think the way they're doing it is making them rise above the rest. But we here, as a pharmacist, are not really showcasing the knowledge we have, not really articulating the amount of the science behind the drug, energizing them, making them aware of the drug, right? And she's also now attempting, apart from her clinical pharmacy background, she's also trying alternative therapies of medicine, which can also help the patient for a faster recovery. So this is in simple right about her, and I wish to hear a lot of her sharings with you all. Wish you all the best. Thank you once again, man. Thank you.
I request Dr. Ahmadi Banu, madam, to introduce our chief guest to the audience. Introduction.
Well, I need to figure out the slides, the way to present them. So I have a
Okay,
flash
okay,
drive. I
okay,
can
okay,
save it
okay.
to that really quick.
Good morning, everyone. Dear faculty and students, we have the honor of hosting a distinguished guest, a luminary in a field of pharmacy practice, Professor Karen Beth Bohan, a professor in a department of pharmacy practice at Binghamton University. Please join me in extending a warm and heartfelt welcome to Professor Karen. Professor Karen illustrious career in the pharmacy practice is marked by her unwavering dedication to advancing the field through both education and research. With the wealth of experience, she has made significant contributions to the development of clinical pharmacy practices and has been instrumental in shaping the next generation of pharmacists. Her work, the spirit of innovation and excellence, qualities that her work embodies the spirit of innovation and excellent qualities that we at VIPER deeply admire and strive to emulate. Throughout her career, Professor Karen has been recognized for her exceptional teaching, her commitment to mentoring students, and her research and her publications provided invaluable insights into clinical practice. And her leadership has inspired countless students and professionals in the field. Professor Karen presents her today is not only a testament to her global influence, but also a unique opportunity for all of us to learn from her vast knowledge and experience. Her visit signifies the importance of international collaboration and the exchange of ideas, which are crucial for the advancement of pharmaceutical education and practices. As we gather here, I encourage each one of you to engage with Professor Karen, absorb the wisdom and shares, and be inspired by her journey. Her visit is a significant milestone for VIPER, and I am confident that it will leave a lasting impact on all of us. Once again, on behalf of the entire VIPER family, I extend a warm welcome, Professor Karen Beth Bohan. We are honored to have you with us, and we look forward to an enriching and enlightening experiences. Thank you. We are the coordinators for the overseas, my dear students. Please be very confident about your, whenever you will travel to US. This is we have our collaboration with Binghamton University, myself and Dr. Dinesh, and we will be interacting you shortly. And she will also be giving you the introduction about the university. And thank you so much.
Now I would like to hand over mic to Dr. Karen Beth. Over to you, ma'am.
Good morning. I am so pleased to be with you here today. This is my very first trip to India. I've been here since Sunday, although it took very far travel for me to get here. So I actually left the USA last Friday And then I got here, I reached on Sunday. So far it's been really great. A little humid. The humidity is much higher than back where I live, but the temperature itself has been lovely. It's just the humidity, but this is a little bit better than Ahmedabad, which is where I was before. So I bring you greetings from the Binghamton University School of Pharmacy and Pharmaceutical Sciences in Binghamton, New York. So Binghamton, New York is in the area of the state of New York called upstate New York. So if you look at a map, you have, this is per your direction. So we have the East Coast here, the West Coast here. New York has a little finger that sticks out into the water. That's where New York City is, Manhattan, Times Square. You all know about that area. We are about 4 to 5 hours from that area. Sometimes you could actually do it in 3 hours, depending upon the traffic. And we are just above the border of Pennsylvania. It's just a small city. And if you just go a few kilometers outside Binghamton, you will get into very rural area like this. So we serve a community of not urban dwellers, but more rural people. We have students come from actually all over the world, but most of the students are from the United States, but all over the United States. We have a PharmD program. It's a brand new doctor of pharmacy program. The first intake of class was in 2017, and then we subsequently developed a Master's of Science in Pharmaceutical Sciences and a PhD in Pharmaceutical Sciences. And we have world-renowned leaders at the top of our school. You've heard them mention Dean Nagaraju. He and our Associate Dean, Dr. Hoffman, have owned some drug companies and a biotech company, and they spent 30 years studying the treatment of muscular dystrophy. So Dr. Hoffman is a geneticist, and he identified the gene for Duchenne's muscular dystrophy, which is a very rare disease with male children. And today the therapy is a little bit better for them, but they used to die by the age of 13. And one of the mainstays of therapy for them is steroids, but steroids have a lot of side effects, and they may grow older, but they'd be short in stature. So the new drug that just came to the market and was approved by European EUA and then FDA is called vamorolone. And if we get the slides working, I'll show you that. But it's a novel steroid that all of these side effects and is going to help this rare disease. We also have a lot of other pharmaceutical research scientists, and then we have our pharmacy practice department, the PharmDs, that also research the clinical care of patients. And we have people researching a wide variety from bench research, translational, and even clinical trial management. We have, and so I understand that some of you might be interested in learning about educational opportunities at our school, particularly in the Master's of Science program or perhaps the PhD program. So we have our MS program is a 1.5-year program. We only have one intake a year. It's in the September, end of August, September. And if you make very high marks, you have the opportunity to do the program in just 1 year. Some people need a little bit longer, or they just want to, spread out the education a little bit, so they take 1.5 years. The program is not a thesis program, but it is will teach you a lot of analytical skills, and you get to use all the instrumentation. Well, maybe not every single instrument, but a wide variety of instruments that we have at our pharmacy school. And we even have teaching labs with this equipment so that you're not going to mess up any of the experiments that the faculty are working on. So one of the highlights of our program that makes us a different program for the masters than some others is that you do have all of this hands-on experience. And we bring you in, we have to teach you some of our coursework to prepare you for the skills. And then you get an opportunity to learn all the different techniques. You learn about what our research scientists are studying, and you identify areas that you're interested in. And then we also include an internship a 6-credit internship that's required as part of this program. You can choose to do it on the Binghamton University campus with one of the faculty if you find someone that you're interested in their work, or you can choose to do it in our pharmaceutical industry. And the people ahead of you have paved the path because the ones who have the first couple of classes have had to work with the industry and try to achieve those placements. If you get the placements in the industry, and it really is up to you to, like, we'll help connect you and give you ideas and help you know the process by which you can reach out to the industry and, you know, make the connections. But from then you have to do it on your own. You have to essentially convince them that you are worth taking a risk on and having you come into their facility and work with them. Those experiences are paid experiences, and they're fairly, you get a very good salary for that, for the 6 to 8 to 12 weeks, however long the experience is. In terms of coming to the United States to study, if you choose to come, you would come on an F1 visa, which is sponsored by the university. Okay, wonderful. So this is our brand new building. The state of New York gave us a grant of $60 million to build this facility. And we entered this facility in the fall of 2018, so September 2018. And all of the spaces are designed specifically for the researchers we have in our curriculum, in our school, and for the pharmacy practice students, the PharmD students. And I'll show you some pictures of that facility later. Even though you can't see it, I don't have a current picture. On this side of the building, we actually have another structure. It's not quite as tall. It goes up to about here. It is our new research and development building, and it's beautiful. It's not quite open, but it actually might be open before I get back on my trip. It's very near to being open, and that will house our animal facility. Currently, our researchers who work with animals have to go to our main campus across town and do their research over there. So they're very excited for this to finally be open. And then you can't see it on this picture, but off to the side over here, kind of along this wall, is our big School of Health Sciences. That's a $100 million renovation project of an old historic shoebox factory from the town from a long time ago, and that houses our nursing programs, our physiotherapy program, occupational therapy, speech, so those clinical programs, as well as the university, upstate university medical students as well. So for our PharmD program, for the clinical side of school, we have students from all these health professions that can interact with each other and learn what each other does. And our engineering programs are mainly on the main campus. I don't have photos of that, but our main campus is also quite impressive. And it's not really that far. When I say it's across town, we're talking, you know, a 10-minute drive in a car, or we have buses for students that run across campus. To just give you a little bit of orientation to where we are, this is the east coast of the country. Here's Philadelphia, here's New York. This is this little finger I was telling you. Manhattan is right down in here, and then this is called Long Island. And Binghamton is right up here. This dotted line, if you're able to see that, is the border of Pennsylvania. So we are right on the border of 2 states. It just takes about 15-minute car ride to get into Pennsylvania. And the university I used to teach at before I went to Binghamton, which is much larger public university, was down here in central Pennsylvania. And up here we have some beautiful lakes, and this is one of the big Great Lakes. I think that's Lake Ontario up there. The students on our campus, just to give you some idea of like the student experience, if you would decide to come experience Binghamton, we have lots of trips to take you into New York City. So if you, every year we have bus trips that you can register for a place on the bus, and we'll take you into New York City to do special events there. We also have buses that take you around to all the shopping areas and across campus and everything like that, and to the movie theater and things like that. Plus, we bring in a lot of like singers and bands, and we have festivals on the main campus. So it's a hopping place. The pharmacy program is a separate little health science campus, but you can always go over to the main campus. So we are part of the State University of New York system, which has 64 universities throughout the state. And we are #1 among that, as they mentioned, as well as we have very high ranking among public universities in the country. And Forbes magazine just named us as one of the new Ivy League schools due to the very positive outcomes and job placement rates, along with the low tuition. The out-of-state tuition, which I will go through that a little bit later, is the same as the international tuition. And when we joined Binghamton University, our dean and his whole team came and bring all their multi-million-dollar NIH funding grants, which actually elevated Binghamton University within the state university system and elevated us to a Research 1 level institution. So, and that was like from my own faculty that I work with. So I've been there since the beginning of this, actually a year before the school opened. I started in 16, and we started our first class in 17. And Dean Nagaraju, who was here before, he and I started together. He is now, we were both chairs of pharmacy practice and pharmaceutical sciences. He is now the dean, and I assist him in a variety of things for the university. I've had a lot of experience. I was 13 years in another university before Binghamton, and now I've been there 8 years. And I was 15 years in clinical practice as a pharmacist before that. So I kind of fill in wherever I'm needed. So he says, hey, can you help me with this? And I step up because I really like to be of service to others. I also carry a teaching load, and I'm in the classroom and enjoy working with the students as well. This is a picture inside one of our labs with students. This is Tony Davis, one of our medicinal chemistry faculty, and I'll show you later a slide with research focus, but natural products, which I know is a big interest here, that's one of his interests and focus areas as well. This student actually went on for this is a PharmD student. He went on for 2 years of postgraduate training. Actually, I think he's in his 2nd year now. So he's one of our bright stars in the program. Now did you save the other slide deck too? If we could transition. I had problems last night merging the 2 slide decks. So I have another one that we can go to. I think it's that one there. No, let's see what else is there. Yes, there. Sorry, I guess it's a PDFs. So I'd like to talk you a little bit more. I've mentioned a few of these things, so we'll skip through some. But basically, we have the MS program and the PhD program, and the PhD program is mostly like a 5-year program. Some people are able to be very industrious and finish it in 4 years. And these are the split of the credits and things. This is an example of one of our classrooms. As you notice, there are not risers. There's not seats like you're sitting in now. We actually don't have any lecture halls like this. All our lecture halls, well, we have one lecture hall where you are sitting at little desks, but and separate desks, but those desks can be arranged to work with other students. But our main classrooms, we have 2 of these. They fit 114 students each, and the desks are arranged. They all have outlets for charging your laptops. Our students bring their laptops to classes all the time. We provide materials on the LMS ahead of time. They take notes. We also there's 2 screens at the front, but there's also screens, LCD screens on all of the walls. So no matter where you're sitting in this large room, you're able to see the material. We even have a screen that students can remotely pull up their own work and share it with the class, because we do a lot of interactive teaching. It's called active learning, and a large part of our program is not just lecturing to you, but rather for example, we might introduce the concepts for the day, talk about it for 10 minutes, and then give you and your classmates at your table an assignment to do. And so then you'll talk among your peers, and maybe you even prepare a PowerPoint of whatever the answer, the answer that you want to provide. You can put it up on the screen, or you can just choose somebody to be the person who presents it to the rest of the class. We also use a lot of interactive technology, so clicker, audience response technology. We play a lot of games in the classroom. Sometimes we put students in teams and they compete against each other as they're learning. So we try to keep it very engaging. Student engagement is a very big importance to us. We know that the more you engage with your material, the more likely you're able to remember it better. So we have an ultra-modern building, as you saw the outside of it, and because we've been able to attract so many high-level researchers, and we give a very hefty startup funds for them, we've been able to outfit this building with top-notch equipment. So you can see on the screen a variety of the type of equipment, and these are some screenshots from our labs. And we work with both undergrad students from programs all across the campus. So we have a big biomedical engineering program, and a lot of their students are working in our labs, both at the graduate level and the undergraduate level, as well as just bachelor chemistry, biochemistry students come to our labs. And I get questions from students all the time. How do I work with your faculty? And so I always have to sit down with them and explain that in order for you to get ahead and get positions in these labs, you have to be willing to give of yourself first. So it usually requires a volunteer experience. But even to secure a volunteer experience where you can work in the lab and be trained on the equipment, you need to do your background research. You need to, and I have links later that when you get the PowerPoints, you'll be able to go to our website. But what I ask of my students, and what you can also do, is you go to the website, you look at the faculty profiles, you see what they do. If it's of interest to you, you click on their Google Scholar, you look at their papers, and then when you reach out to them about opportunities, you phrase it like, Dr. Jones, I see that, I looked over your profile on the Binghamton website, and I'm very interested in your work on XYZ. I've been doing this, and I've been studying this, and I think that I could learn from you. I also read a few of your papers and was impressed with this, that, or the other. So it shows them that you actually care about what they do. And then you say, I wonder if you have any research assistant positions open, paid or non-paid. I'm very willing to come and volunteer just for the experience. And then when you come in and volunteer, you have to be timely. You have to have a good work ethic. You have to learn the skills. You have to interact with them, engage, ask them questions. Don't just sit there and expect them to be like feeding you information. It's a two-way street. And this goes really for anything you want to do in life. The more you put into it, the more you get out of it. But anyway, then they learn your skills, they learn your interests, they learn your abilities. And then when a paid position comes up, you're the first person they think of. And our researchers have contacts in the industry, and that's called networking, and that's how you then gain entry into meeting with these other people. And then the next thing after that is you go look at their LinkedIn profiles and you reach out to them, and you might have to reach out to 20 people before you get somebody to give you an email back and want to interact with you. But you just have to be persistent at it. I know you can't see this very well, but you'll get the slide set. But just to give you an idea, these are the 3 semesters in the MS program. And we have Pharmaceutical Sciences 1, and this is a fall course. And then this is why we have a 1 start per year, because all the coursework here is needed before you have this coursework. So, and then we have the big analytical methods and instrumentation courses. That's what I was talking about. Actually in a training laboratory, able to work on this equipment. If you make a mistake, you're not going to ruin anybody's research. And then actually when you go to apply for internships, or even when you graduate for jobs, you need to write a cover letter and prepare a curriculum vitae that it really highlights your abilities. Don't just like list what you've done. Oh, I've been here, you know, I got this degree, I did this, I did that, you know, during these timeframes. You can add little bulleted items under there. I am trained in, you know, quality management or drug analyzation on whatever the equipment is. And then you write a cover letter that explains exactly what you do, what your accomplishments have been. You need to learn how to advocate for yourself and sell yourself to them. And if you don't get your position, don't give up. Just keep your eye on the dream that you have and gain more skills, and you try again. So in terms of the market and demand is pretty high in, at a national level in our country. So there's an undersupply of workers in the pharmaceutical industry due to the rapid growth of technology. And the benefit of us being a brand new program is that we were able to design the curriculum and the experiences for students to meet the needs now and in the future. One of the things with the schools that are very well established is it's very hard to catch up as things are changing so frequently. And purchasing, you know, $1 million pieces of equipment isn't something that you can do on a whim. You have to plan ahead for that. So in terms of salaries, this is the basic range of salaries that you can get in these fields, and then the growth rate for that and the type of sectors that you're working in. So industry certainly, but there's also academic labs. We have, I actually think I have a slide on that later. There's federal labs working for the FDA and the NIH and a variety of companies. So in terms of the placements of the outcomes for our graduating students, now the MS program is brand new. I think we only have 2 classes graduated so far, and we don't have any PhDs graduated yet. They are in their 3rd year, I think, right now. So we don't have those outcomes. But the F1 visa allows you to get 1 year of OPD, which is occupational practical training, where Binghamton University still sponsors your visa. So you can apply anywhere, because a lot of times the employers say, they, you know, at the bottom it says, we don't sponsor visas. Well, you don't need to worry about that, because the first year, Binghamton will sponsor the visa. And once you secure your position, Binghamton University works with that employer to make sure everything is aligned with the government. We don't want something to go wrong and you be, you know, sent out of the country. Unfortunately, the US government doesn't recognize the field of pharmaceutical sciences as a STEM field, so it's only 1 year of OPD, whether it's the pharmacy school, MS, or PhD in pharmaceutical sciences. However, if you're working for a company and you've shown how well you can do, they will often then pick up your visa after that, or at least you can share your experiences and you know, be able to get an employment in another company. We've successfully placed all of our graduates in the MS program so far. Some of them have gone into the pharmaceutical industry. We have some that have chosen to work in an academic lab, so in a university somewhere in the US, working in those labs, or even on our own campus in the labs. And it's a very excellent pathway to our PhD program. So our PhD program is highly competitive, and I'll tell you a little bit about that at the end, and you'll see why it's highly competitive. But especially for international students, if you go to the MS program, you get to work with their faculty. You know what they do, they know your abilities, and we've already had 2 students from the MS program go into our PhD program. So that's a really good path to do it. This is the PhD didactic curriculum. I'm not going to really go through all of that. And then this is the career possibilities for our PhD scientists, as you can see on the screen. For admissions, the admissions to both programs, the MS and PhD, are the same. You must have a bachelor's degree, and that bachelor's degree can be in any discipline. It could be in English if you're, like maybe you went for an English degree in literature and you totally changed your mind and you took the right courses that are listed there. You can come to our program and do an MS or PhD, even if you had a humanities degree. Of course, that is a very wild example. That's not really what happens. But so all of your programs here, I'm pretty sure they, if they don't have all those courses, you can just add a course and fulfill the prerequisites. You need to have 12 credits or more in high-level chemistry, biology, physiology, etc. You do need to have pretty good marks. So we use a 4.0 scale in the United States. You could just do ratio proportion to the 10.0. Do you use 10.0 scale? Yes. So so that would be roughly, well, exactly 7.5 out of 10. It is also competitive, so the higher the marks are, the better your chances are. You do not need to have the GRE. So if that is something that you haven't already done, which is a graduate, I forget what it stands for, but it's an exam to qualify for graduate school. You don't need to do it, it's optional. I don't think it's worth paying for, but if you did do it and you have good marks on that, it will definitely help you. If you are, maybe your grade point is like 3.2 or whatever that it accounts in your system, and you want to be more competitive, that might be a scenario where you take the GRE, where you can show I'm actually better than what my scores show. So that might be an area where you might take that, but you don't have to take it. The application fee is a bit hefty, but that's kind of the way it goes. And there unfortunately is no scholarships for that, for international students. There's no waivers, I mean, for that. In fact, actually, that's another thing. There's no scholarship money right now for our MS program. I actually talked to the director of our program. I'll give you his contacts later, Dr. Yetrup Halthout. And he said that right now our MS program is in a rapid expansion phase. We don't have, I think our class size is 14 or 15 right now, but it's going to be 20 for the next intake, not the one that's happening right now. But we project it's going to go up to about 50. But we are working on a long-term strategic plan right now. So right now it's still small. We've only been in operation for 8 years and not even students for 8 years. This is the last bullet is the very big benefit for the PhD program. Not only do you get to work with high-level, world-renowned scientists, but it's almost free for you. That's why it is so competitive, and it's why we are getting huge numbers of applications for our program. On our main campus, we have a very big program. The School of Engineering, called the Watson School of Engineering, has many more MS slots and PhD slots. However, they do not provide the funding for all of their students, only for a small fraction. But right now, we hope to provide this model, and we can do it because our researchers are successful at receiving the NIH grants, which helps them to support this program. So basically, you will get a stipend for all your tuition. And in return for that, the first 2 years of your PhD program, you spend 20 hours a week in a teaching assistant. Now, the teaching assistants in our program, it sounds like 20 hours is a lot. How can I manage that? But it's actually extremely doable. Our faculty teach our classes. There's not a single class that is taught by a teaching assistant. The teaching assistant role is simply that. We assist. They tutor students. They mark exams and assignments. They help proctor exams. But they don't have to prepare massive amounts of teaching materials. So they do have a lot of student meetings. The students go to them all the time to interact with them, to learn the material in terms of tutoring. They review examinations with them when they don't get good marks and help them to improve. But so it's really doable. It's not bad at all. So you do that the first 2 years while you're doing, and this is the PhD program, most of your didactic work. You do have some experiences in the lab, but not on your own dedicated research. The second 2 years of the PhD program and beyond that, you are working in the lab. You don't have to do the teaching assistant anymore. So you're working with your faculty mentor, you're developing your own independent research, and we're helping you apply for other grants and other funding to carry your work further. I think I didn't put it on the slide, but there is something called the Clark Fellowship, which is some funding that is available as well, and that would be for master's students too, but that's highly competitive. But once you get accepted to our program, all of any scholarships that are available, which are not a lot, but we will send that out to you and you apply for that on your own. So how do you get, what's the admissions process? What does it look like? It's multiple steps, and maybe in some ways it might be a bit different than what you go through here. There's application, that is an online application. You have to write at least a 500-word essay, which is a personal statement, talking about, you know, what do you want to do? Why do you want to do it? Ideally, now it says here with mention of a possible current, and we abbreviate our name as BU SOPS. So a SOPS faculty member, and that goes back to what I told you before. You got to research the people there, research what they're doing. So in your personal statement, when you say, hey, not only do I want to come work with you, I know about you, I've read your papers, I have these interests, I can contribute, this is what I want to learn, this is what I want to do for my future goals. That kind of personal statement is the one that really catches our eye. You will need letters of recommendation, and the letters of recommendation need to be more than this person is in the top 10% of our class, they came to class on time, and I recommend them. You want to work with whoever you want for your to get the letter from, which would ideally be faculty here. Say things about you as this person is highly dedicated to learning, they've achieved high marks, but they've gone above and beyond to help perhaps students under you to learn the material, or to tutor, or they are always in the lab, or they're asking for extra work, they're going the extra mile, whatever is appropriate in what you do. You want them to be able to talk about you from a point of knowing you and your abilities. This is the same spiel I give to all of my pharmacy students going for their clinical post-grad opportunities. And I think there's some faculty here too as well as the students. So now faculty, you are hearing this as well. So if people come to you, you need to have a robust letter to support them, to give them the best advantage. And for our PharmD students, so I'm a clinical pharmacist, I didn't really go over all that lab equipment because I don't really understand the lab equipment. I know the names, but I don't know what you can do with it. I'm definitely a clinical person. So with our clinical faculty, with our clinical PharmD students, about a third of our class wants to go on for post-grad training. And a lot of times they'll come to me and they want me to write a letter of reference for them. But if I don't work with them in the clinical practice site, I can't attest to their clinical skills. So I explained to them, you need to go to those preceptors, the pharmacists that you worked with, and get them to write your letter. And then I also explained what I just said to you about how the letter should not be perfunctory. And you need to figure out a way to explain that to them that you want a letter like that. And an example of a way to do that is you have a person-to-person, face-to-face, not a WhatsApp chat, not an email. You go to them and you say, I'd like to do this, that, or the other. Would you consider writing a reference for me? If they say yes, and then you say, and I will send you some of my materials. I'll send you my CV. I'll send you a list, because I will ask when I do work with a student, I'll say, send me your CV, send me why you want to do this, a personal statement. I will sometimes meet with them. But anyway, you have to, and then I also say for the clinical people, like if you've made a positive impact in the care of any of your patients, remind them about that. And this you do in a follow-up email after you have that face-to-face conversation. You send them the CV, etc. And you say, remember when I was with you and we had the patient who had the diabetes and they weren't taking their medicines and their hemoglobin A1C was really elevated, and I interacted with them for several days over a month time frame, and by the end of that, their A1C came down. You'd have to jog their memory. These people work with lots of people, lots of students. They're not going to, even if you had a close relationship while you were there, unfortunately, they're just not going to remember everything that you did. So you have to advocate for yourself. Proof of English proficiency is required with those scores. Our website, if you just Google our website, some of the other programs only require 80 for the TOEFL. We do require 100 or greater for the School of Pharmacy. Any of those are fine. You don't have to do more than one. And we may have vouchers to pay for that. So if you don't have the funds to pay that, the admissions process, once you're applying, you can go through there and they can give you vouchers to cover that. Also, interview. I don't know if you have to interview for your advanced degree programs in this country, but we interview both PharmD candidates as well as all of our MS and PhD students. And obviously, that's a Zoom interview. However, when I'm interviewing people for our program, international students, often they don't have the proper interview skills. And some of it I know is cultural. One thing I didn't really mention, but I've done a lot of work in Uganda. Over the years, since 2011, I've been there like 13 or 14 times, helping to advance pharmacy practice and education in that country. So I've learned a lot about at least their culture, and some of that I think is more in common, to your culture than it is to the US. But anyway, a lot of times I see students not wanting to look up. And I think it's out of respect. There's somebody higher up than them, so they're not having direct eye contact. Well, we want you to have direct eye contact. To us in America, that's like, I don't care, I'm apathetic, I don't really care. So we also want you to ask questions. It's when we say at the end of the interview, after we've grilled you with all kinds of questions, and we say, what questions do you have? Do not say, I don't have any questions, none. That's our opening for you to tell us how you're interested in our program. And even if you've done a lot of research, even if you've talked to 5 other people about our program and you got all the answers you need, you still repeat those questions. You get that new faculty's take on whatever the question was. Just come up with something interesting and meaningful. We want to have engagement with you. And this is also how we keep an eye out for your oral communication skills. I personally would be available to walk you through some of this if anybody is interested and puts an application in and is granted an interview. If anybody wants to work on that with me or just have another refresher of the things I've been talking about, you can get in touch with me, or I can get in touch with you. I can even put you in touch with students that can help you understand what that process is. But our interview process is very, very important, especially if you're thinking the PhD program, since that's highly competitive. And then after the acceptance, which if you are accepted to any of our programs, as an international student, you will get a provisional admission. Provisional means that is a full acceptance. However, you can't be accepted to come to the US until you can prove financial viability for your visa. So the faster you can get that information into us, the faster we can then send you the real acceptance letter, and you can start all those multiple processes that need to take place for you to actually get to the US and matriculate. We also have, so I've been, one of the tasks that Dean Raju has had me do this past year is help supervise and lead our admissions department. So we do have admissions staff that can also independently work with you on all of these things. And we want you to ask the questions. Don't struggle through this. We want you to be successful. I'm not telling you about this because I want to say no to you. I want to say yes to you, but you have to show me that I should say yes to you. We do a rolling admissions, and we'll have a deadline March 15th of the year before you would start. As I said, the starting is in the fall, end of August, but the application deadline is March 15th. But as with many deadlines, and I do this as well, you give me a deadline, I wait till the end of the deadline, right? Okay, the deadline is March 15th. If I apply March 1st or even the 14th, I should be fine, right? Wrong. You are competing against other people. The rolling admission means that we don't collect applications and then sift through them and rank them. We address them on a regular basis. So you want to apply as early as possible. And of course, you're going to still be in your curriculum. You may not have all the prerequisites. You may not have all your grades. That's okay. We don't expect that. We know you have stuff to finish up. But the earlier you can apply, the better. Because as the deadline gets closer, we've been filling seats. You're going to have higher marks and higher qualifications to get those last remaining seats. So don't delay, apply early. Even if you are, I don't know what years you are, I'm sure we have a variety of years here. Even if you are just starting, but this is intriguing to you, it is not too early to reach out to me, to reach out to Dr. Yetrib Hathout or Dr. Nathan Toomey and say, hey, I am at, SVES, et cetera, whatever you want to say about yourself. I'm just starting this program, but Dr. Bowen was here and talking to us, and it got me excited. And I think I want to prepare to do your master's program. Can I have a meeting with you, a Zoom meeting to talk a little bit more, and so you can get to know me? It's not too early to do that, even if you don't know very much at all. It's okay. That way, we've seen you early on, and we might remember you later. And even if we don't, you can always say, remember, I contacted you way back when we had this conversation. And I'm going to provide all these slides to the principal so he can get them all out to you. So I need to go back to the other one now. Do I still have a few minutes? Because if not, we could stop. Okay, good. That one there. Yes, okay. So now I want to go through the areas of research focus for our faculty, and then I'll finish up with just a little snapshot of the PharmD program so you can kind of see a little bit about how we train PharmDs. So the drug that just got approved in the fall, last fall in 23, is vamorolone. And the brand name in the United States, I don't know if maybe it's the same brand name across the world, I'm not sure, but Agamree. And I'm sure that there's a story behind that. I just don't know what that story is. And I pretty much talked to you through all of this, but this is Dean Nagaraju, and this is Associate Dean Hoffman. These guys, I know them from the perspective of being a colleague of theirs. And so I don't do their research area. I'm not even in their discipline. And so I got to know them in a casual way, and they are the nicest, down-to-earth people you will ever meet. Dean Nagaraju has a smile on his face all the time. Dr. Hoffman, he's just wonderful. It's just very casual. However, if you go to a professional meeting, these guys are super huge. People to work with them is super huge, and it's kind of funny for me because we see them as like regular people, but they are really great. This is just a little infographic of our faculty. I have 2 additional faculty I'll tell you about separately that this is a couple years old. So you can kind of see the general areas, but I'll just tell you in the areas. So we have a big area and a number of researchers on the muscular diseases, myositis, Duchenne's muscular dystrophy, and in that realm. We have cancer researchers. Dr. Tracy Brooks here at the top, she does anti-cancerous therapeutics. She's a pharmacologist, and she's special interest in breast cancer, but she also looks at other types of cancers, drug target development. Dr. Zhang is a pharmaceutics faculty. He looks at preclinical absorption, drug metabolism, but specifically breast milk, drugs and lactation, which is a very understudied area in our country. So he looks at that. Dr. Morales is part of the myositis muscular dystrophy team. Dr. May is one of our newer pharmaceutics faculty, does lipid nanoparticles, drug delivery. Dr. Toomey, very interesting past for him. Dr. Toomey's only been with Binghamton University about 5 years now, I think, but he was with Pfizer drug company for many, many years. He's got a ton of publications out there, so you can see those. He is a medicinal chemist and does antibody drug conjugates. He also loves to work with students. He has one of the most active labs on our campus, tons of students working with him. We had Dr. Nagaraj and Hoffman are down here. We also have a totally different area in our pharmaceutical science. Dr. Rattinger is a trained pharmacist, PharmD, but she also has a PhD in chemistry, and she worked in the industry for most of her life. As an older career, late in her career, she actually went to pharmacy school. So she's older than I by about 10 years. However, I have quite a lot more pharmacy experience than her because she was a scientist before, but wanted to do the practice things. And now she does what's called health outcomes research, large database research, and she specifically looks at Alzheimer's disease and children with special needs. And then Dr. Davis, as I mentioned, he does natural products with infectious diseases as well, drug development. Dr. Edwards has really interesting research as well. She's looking at thiamine deficiency and also thiamine, and she uses, she's looking into the fish in our streams and waterways and looking at their health and the thiamine levels there as well. She comes to us from Cornell University, which you may have heard of Cornell, which actually is just about an hour from our campus. Jared Bagley is a new faculty to us. He comes from the psychology department at the school. So he's been at Binghamton for a while, but then he wanted to, we have a focus in opioid dependence, opioid use disorder, and he studies that. So he, behavioral pharmacology. So he came over and he collaborates with some pharmacy practice faculty on his research, neurology, psychology, specifically with drug dependence. Yan Li is the wife of Dr. Tao Zhang, and she is our newest faculty, and I've not had a chance to actually meet with her about her research yet, but it's an area I'm highly interested in because she does the gut-brain connection, microbiome research, and also into nutritional dietary factors and things. So microbiota and drug development discovery. And I've only interacted with her casually. She's super nice. So you'll have the link to their profiles on these slides, but that's where I was saying, go to this link. You can scroll down all the different faculty, and then there's actually another link, and it says like full profile, I think is what the link says. You click on that, you get a bigger synopsis, and then you get the Google Scholar link. And going forward, our whole university, there was a huge amount of grant funding coming out of the US and the state of New York, and we were able to compete for a big chunk, and the university as a whole decided that these are going to be some of the research areas. Well, there was a whole list of research areas. These are the ones that tied in, that Dr. Nagaraju chose for our School of Pharmacy. So we are right now hiring faculty in all these areas. Now, neuromuscular disease, we've been doing that for a while. Opioids, though, but the aging area, that's a really big area. So we're hiring people in that as well. Is it time to be done? Yes. Do I want another minute yet? Or do I need to stop like this? Okay. Okay, I'm just going to quickly go through pharmacy practice. These are our pharmacy practice faculty. We have people doing, just so you have an idea, like people specialize in areas. We have psychiatric pharmacists, pain management pharmacists. We have 3 different cardiology pharmacists, critical care, oncology, infectious diseases, global health, emergency medicine, women's health, lots of different areas. That's their profiles. I'm just going to show you some quick pictures of our lab, or we call it Pharmacy Skills Lab. So it's not bench research, but it's our simulation center. Just a few of those so that you can see what that looks like. We also teach all of our students how to give immunizations. The US gives a lot of immunizations at the community pharmacy now. They have to become certified. And they do that, they actually have to give each other injections. So these are 2 students, that's sterile saline in the syringe. They have to do that appropriately and be assessed for that. And it is a pretty scary thing for them. A lot of them didn't think as a pharmacist they would actually be doing a vaccine. This is one of our simulation mannequins. We also use, this is an elderly person in our community, a regular normal person, and she acts as a standardized patient for us. She pretends to have problems that the students can interact with so that when they make a mistake, they're not going to harm her. But it gives our students a way to work with somebody they don't know in a safe space. These are some of our other facilities. Our PharmD program is research required. And so all of our students do a 2-year research program, and we do poster fair on campus. But we also have about 30 students every year go to a national meeting, which is a competitive thing. You have to put a proposal in and get it accepted. But this last year in December, we had about 30 students get their posters accepted to a national meeting from the work they're doing. And these are all faculty mentored research. And then we also have training, as I mentioned earlier, with the allied health science faculty across the other, and they do a lot of community outreach as well. These are some of our certifications, and I think we probably don't have time for questions, right? But okay. Thank you so much for your attention.
We'll have a break for 15 minutes. Please come back by 11:15. And session will continue after the break. Also interaction, or if you have any queries on higher education in BU, you can contact ma'am after the break. Now, after the break, come up with your questions for higher education in Binghamton University. Okay, thank you.
And helping young minds to nurture the ideas and then transform into a startup. Then also we learned that role of innovation ambassadors in making institutions improving the performance of institutions. Then in our last MIC driven activity, we learned about another important program that comes under the IIC umbrella, that is uh, on, on the session. What is that, Abhishek?
Excuse me, sir.
What was our second last MIC driven session?
Second last session is on overall IAC.
Huh?
Overall IAC, as per, basically IAC, right now we had covered ATL, we had covered, we are
So
now going to cover.
in our MIC driven, the second was covering that how these IICs will play the role of as a mentor to these schools. So how to bridge the school and higher education. That was the focus. And again, the role of IIC comes into the picture. So today we will focus upon how IIC institutions and especially innovation ambassadors also play an instrumental role in improving or generating or helping our students and faculty members to work on their ideas. What institutional mechanism actually we need in our institutions, and where IIC will drive it and create a system or a mechanism of identifying the potential minds or the creative minds, then engaging them in the ideation process, then scouting these ideas through this mechanism, and then nurturing them to build the ideas, prototypes into innovation and startups. And also this system will help in identifying or scouting the inventions made in our institutions, like in IP intellectual properties, mobilizing the resources and putting concentrated efforts to nurture these ideas, innovations, inventions, and startups for their growth. So this is the mechanism. So IIC as a whole is an institutional mechanism or framework at the institute level, which brings the resources from the different sources and bringing the institute departments, uh, faculty members, experts, and students, and ensure activities. But engagement of innovation ambassador, engagement of IIC for mentoring to the operating labs and the schools, then driving the repository of ideas innovation is the another dimension. This is what we're going to discuss today. So I'm going to talk about the Yukti innovation and IPR repository that every institute has to build and maintain it and use that repository as a pipeline for their incubation and the pre-incubation units, and also they will use this this database for providing mentoring and funding supports at the institute level, and wherever required, they can refer the ideas, innovation, startups with ecosystem enablers exist in the region
introduce yourself before asking questions and then that would be good. Boys.
Any queries, please come forward. Please be seated, ma. Whoever is interested in asking a question, please raise your hand so that we will get you the mic.
You can. Can I ask him? Hello, madam. Before the students, I just have one question.
Sure.
I'm Archana, Faculty of Pharmaceutical Engineering. You have shown the curriculum of your MS program. Can you elaborate what comes under pharmaceutical sciences? Because we were not able to, see that in the website as well.
Right.
Thank you.
Sure. Good question. That's a big title, and there could be a lot of different things, right? So, pharmaceutical sciences class covers many disciplines. And actually, that particular two-sequence class is done with our PharmD students. So that's a joint class. It's PhDs, actually, yeah, I think it's PhDs, the MS, and the PharmDs. So, and then the PharmDs, there is a little bit of content in there that those MS and PhD students don't take, and then they have a separate class. It's kind of like a mixed hybrid class, but most of it is all of them. So it includes, there's some immunology in there, there's some biochemistry in there, there's receptor theory in there, there's some pharmaceutical, what's it called? Like how drugs are developed, some pharmaceutical type stuff in there. And I actually have never been in the course, so I don't know exactly how it works, but it's a hodgepodge of a lot of stuff. And it's one of the courses that is very uniquely tailored to what comes next. So instead of having, so some of that content will absolutely be repeated from what you've had before. If you're in a pharmaceutical program, not an engineering program, it would be all new for you. I'm guessing if you're an engineer, but it's put together in a different way, and the materials overlap each other, and there's application as well in there. So, but if you need to know much more information, I can get you much more information about it. Yeah, I have to reach out to the director to get a syllabus. Yeah. Yeah.
Thank you, madam.
Sure.
Good morning, madam.
Good morning.
My name is Fasi Ahmad. I am from Yumfarm Analysis Department. So my question is, what are the requirements for the PhD program in Binghamton University, and how much percentage is necessary for the admission of PhD in Binghamton University?
So what are the requirements for it, for admission? The prerequisite. Oh,
What is the criteria to get into PhD for MPharm students?
it's the same as I had up there. There was a slide that said admission requirements, and I went through that, and it said there was 12 credits in advanced biology, whatever it said up there, chemistry. That's the same for the MS and PhD. So, yeah, that's just, pretty much whatever your undergrad, let's go back to the example of the English, humanities person. We can't take somebody who's got a bachelor's in literature into the PhD program if they don't have the core sciences. But we teach you everything you need to know about the sciences in our program. And that's why that pharmaceutical, that course that you mentioned is very tailored to what is needed. So instead of having you say, oh, you need a whole immunology class, you need a whole class and all these different things, we're teaching you bits and pieces and putting them together in a way that meets what's going to come next. So so if you have, the other thing is, I'm not sure you are aware, but in the US, you do not have to have a master's to apply for PhD. So you can go with, so if anybody has a bachelor's degree and want to go to PhD, you can go directly to PhD. Now, if you have a master's, you're going to probably be a higher ranked person in the application process, but it really all depends on what you have done with the education that you already received. Does that answer your question? If there's, the other thing that we can also do, if you're interested in any of our programs and you want to have a one-on-one conversation about this is what I have done, is it sufficient? You just email us. And what I would do is, because I'm going to be the contact for you, so I will be connecting you to other people. I won't necessarily review it with you, but I will connect you to someone who can. And that can be done by email. I mean, or if you want to have a conversation, it could be Zoom, it could be, a phone call, WhatsApp call, something like that. But I'm training the admissions staff people to understand pharmacy better, because they come from backgrounds that they do their admission stuff really well, but they don't know the pharmacy stuff. So I have actually been reviewing a lot of transcripts for international students, which has from all different countries, which has really helped me to understand better the type of curriculum, because it is very, very different from what US undergrad curriculums are. Oh, sure, yeah, if you'd like to write down my email, it is K, the first initial of my first name, and then Bohan, B-O-H-A-N, so K-B-O-H-A-N @binghamton.edu. But if you click on the profile link, you'll also find me there, and there's a link to my email as well. But yes, kbohan @binghamton.edu. And then I will either refer you, or I'll take a look at it, or I'll figure out what the next step is. Next question.
Good morning, ma'am.
Good morning.
I'm Chandrasekhar Gaud. I'm currently pursuing my BTech in pharmaceutical engineering. I have a question for you, ma'am. Can you please provide about the placement, career objectives, and placements in Binghamton University?
The question was about
the placements, ma'am.
For the MS program?
Yes, ma'am, MS program.
I also covered that. The placements are after you take your didactic courses in that program, along with all your skills labs, which is teaching about all the analytical equipment, and you will have been working with all the faculty, all the faculty we have in pharmaceutical sciences. They all have bits and pieces of the PhD and MS programs. So you'll be exposed just naturally through your coursework. And that's another thing, going back to the course, we don't have just one faculty teach a course. We have multiple faculty. They all teach their specialty in the course. They also all know what each other teach, so they connect the material. It's a very different model than in most places. That's why those courses are unique. That's why you can't transfer in what you have. Now, I can say that what you have is going to help your learning significantly in those courses, but there's not a course here that would be the same. So anyway, the placements, after you have your didactics and you know the faculty, and you will also have an advisor. And for us, so that means when you first come, you're going to be assigned to a faculty advisor, a full faculty advisor. And they will work with you from the beginning on your career goals, your professional goals, and where you want to go with your placements and stuff like that. And the relationship is strengthened by you interacting with them. Now, there are certain times where we will we are mandated to interact with you, but we don't want to just see you when we have to see you. We want to see you all the time. We want to know what your goals are, your career goals, your interests, where you're struggling. If you don't share that with us, we can't help you get to the next step. So that's who you're going to go to figure out, what should I do for my placements? I really like what Dr. Hathout does. Should I, work with him? What is the likelihood he'll accept me in his lab for my placement? Or is it better that I go into industry, into pharma for my placement? Then also, we have graduates already and students currently in placement in the industry. You talk with those students and you say, we have social activities. So, don't stay just with your own cohort. Go talk to everybody else. What did you do? How did you decide to work with a faculty? How did you get into industry? Or if you got rejections, what did you do about that? And that they give you help as well. So the placement it's a decision between, it's your decision. It's what do you want to do? And if you want to go, most people want to find an industry placement because there's money attached to that usually. But if there aren't paid placements in the industry and you're willing to volunteer, you may be able to get a placement anyway. That's another thing to remember is this is an experience. You want to gain as many skills as possible. If you have to do it without getting paid for it, then do that. It will, believe me, it will reap you benefits later down the line. So if you get a no, like if you go and look at the websites and there's no positions open, don't take that as a closed door. Take that as, well, maybe there's not a paid position. Go to your faculty advisor and say, hey, this company, let's just say Pfizer, they're researching this new drug or whatever, and I think I'd really like to work there, but I don't know anybody there. Does anyone have any contacts? And I can tell you, like Dr. Nathan Toomey, he worked for Pfizer for many years. He has put people in touch with people there in divisions even that he didn't work in because he knows their system. And we have Dr. Dean Nagaraju. In fact, actually, he has such good relationships with many drug companies. One of them had a call for internships because our pharmacy students, the PharmD students, also compete for some of these industry internships as well. So we do send out, big piece of information I left out. When we get the calls for the spots for the internships, we send them out to all the students. So you have to read your email. We send out a newsletter. We compile everything into a newsletter that goes out once a week, and there's a section in there for job opportunities, placement opportunities. Sometimes it's things that you're going to do during an off time, not during school. It'll be during winter break or summer break. Other times, you get to the point in your curriculum where you don't have didactics anymore, so you do it during the school year. Those opportunities are often for all the students in all the programs. So anyway, I forget what the company was, but they had something, with applications, and they and Dr. Dean Nagaraju had sent it out to our students and told the company that he was sure students would apply. And then when it came time for them to go through, review all the applicants, they didn't see any applicants from Binghamton University. So they called the dean up and said, hey, can you tell us, which of these students is from your university? We want to give you first choice. Like we want, whatever your recommendation is, we'll take. And so I was associate dean at the time, and he said, hey, can you reach out to the students and find out who applied? Well, guess what? And this is a student issue again. They don't read their newsletter. They miss the application deadline. They might, and some of these applications are almost a year ahead of when you're going to do. You might not be in the mind frame that, oh, I need to, that this is for me. You might be thinking, oh, I'll wait till it's closer to time. But no, you got to read the fine print, investigate if it's, you have to apply that early. So anyway, so a student, so I sent it out and I said, please contact me as soon as possible if you applied or if you want to do this internship in industry. And I had a student contact me and he said, that he unfortunately missed the deadline, so he didn't apply. So it turned out we didn't have any students apply. But I said, you still want to do it, right? And he said, yes. So he sent me his information. I passed it on to the dean. The dean passed it on to the drug company. And lo and behold, he got his internship. And now he's on the path to do fellowship. And he's got, so I think that's one of the things that Binghamton is really good at is those networking and the connections. And I think you get that with us that you might not get with a much larger, even if they're really well-known university, you may not get that individual attention. But again, you have to go and seek it. Don't just sit in your room studying and never come to see us or never express what your interests are and then expect to have the placement of your dreams. Okay, so if you're talking about completing, I think it's about about what to do. So a student at another university posed the question, and he said, well, I've heard that people do their 1-year OPD, some Binghamton sponsors their visa, but then they can't get a placement after that, and then they have to come back to India. What about that? And so, that's going to happen. There's jobs out there, but the jobs might be in small drug companies that you don't know about. People might think they only know the big names and they only look into the big names, but big names are where you're going to have the highest competition. So you can go and look for the new startup industry, reach out. And also sometimes people like to have, people that are from far away. So be willing to travel. If you come to Binghamton and we're, East Coast US, but maybe there's small startups or places out in the West, be open to that. It looks good for them to attract people from other places. And then, but if you couldn't get your placement and now you have to come back to India because you don't have your visa anymore, if you still have your dream, stick to your dream, get a job, the best job you can get here, advance here, learn the skills, even ask for potentially a follow-up interview or inquire by email. I understand this was competitive and I didn't get the position, but would you please give me some feedback on how I would be a better candidate in the future? You can do that for them. I can't guarantee they're always going to give you that information, but you're not going to know if you don't ask. But anyway, come back here, find those skills, and even if the industry or the person that interviewed you doesn't get back to you, ask our faculty. Go meet with your advisor. Hey, I didn't get it. What do you think I could do to make myself, give myself an advantage? But come back here, work hard, have a good work ethic, develop a really good, strong relationship with somebody higher in the company that's going to advocate for you. Then in a few more years, you apply again and you will get it over the people that are just coming out of their OPD because you now have experience. So you gotta work hard to get where you want to get. I didn't get here by just sitting around and letting things happen around me. I'm proactive. I go and I do things and I work extra hard. I work long hours sometimes, but I tell you what, everything I do has really made me have a good, career. Yeah, no question.
Hello, ma'am. I'm a third-year biomedical engineering student. So you've spoken a lot about pharmaceutical engineering. So it would be really helpful to us if you can let us know about the programs which are available at your university, which are most suitable for us.
Actually, I cannot help you in that area. However, I can connect you to somebody who can. I do not have any information about our whatever you mentioned, biomechanical engineering or biomedical engineering, but we do have a lot of programs, and if you email me, I will put you in touch with the right people that can help you.
Thank you.
Oh, just another thing about if you email me or anybody that you email, faculty or whatever, don't expect an immediate reply. Everybody's busy. But the other thing is don't wait a week. without a reply. Because what happens is our emails keep piling on top. And we may say, oh, I'll get back to them later, but by then we have other emails. So it is perfectly adequate if a week has passed to send another email, a very polite, respectful email, and say, just kind of asking again if they received the email, or I inquired and I know you're a busy person, but can you please let me know, when I should expect a reply, or something like that.
Hello, ma'am.
Hi.
What kind of research works we do there?
Is the mic not working?
I want to know about the research works.
The what?
Research works.
I didn't. What about them?
Research works.
He wants to know about it? I don't know any, for the pharmaceutical science research, I don't know anything more than what I showed you. I'm a PharmD trained person. I do not understand the labs. I've gone to their lecture, and to tell you the truth, I don't really understand half of it. Give me a patient and I can help you out. But I can connect you. I gave you those areas of interest or focus so that you could do your own research on our website, where you will find much more details about what they do. And if you pull up their papers, you'll find exactly what they're targeting. Oh, thank you very much. Hello. Okay. Yeah, so you need to do your own proactive work, and you can either find someone yourself, and then feel free to reach out to me if you want me to connect you to them, and I can send a letter, an email to the faculty that you want to talk to or interact with. And I can say that, I met you when you were here, when I was here in India, and you had more questions about this, that, whatever it is, and then I can put you in touch. The other thing is, our faculty are very busy. Another way to get more information about what they do is to be in contact with the PhD students that they work with. So that might be another thing that you can put in an email. I read your work, I'm interested in this, I'd love to talk to you, but you may be a very busy person, and I'd also, maybe I could talk to one of your PhD students about their experience working with you. And I think also a peer-to-peer interaction might be very helpful. Go ahead.
Hello, ma'am. I am Sarthak from third year, a biomedical engineering student. So, if I did my master's in biochemistry in your university, and I get placed into some pharma companies like NextGen or Pfizer, what kind of H1B will I go through? Is it a lottery system or not?
What kind of what do you go through?
H1B visa.
Oh, I'm sorry, I don't know that information. We do have an international office. I can contact them for you or put you in touch with them. I don't know anything about visas outside of student visas.
Thank you.
I think it is H1B, but I don't know that 100% for sure.
Done with questions? Have you done with your questions? Yeah, I think that. So, we'll request the biomedical and PhD protocol, and we'll ask. Yep. Just 2 minutes.
Sure.
Yes, the students of PhD in biomedical can leave. The bus is ready for you to go to BVRT. You can leave from the back door, right? Thank you. Thank you for your active participation.
Thank you. Could you take a picture of me? Thank you.
Please come forward and sit, ma. All those last benches, last row students, please come forward and sit. Occupy the front seats. Quick.
Are we ready to go? No, I'm fine. If you don't mind, I can sit. What?
You can sit and
Yeah. Oh. Hello, can you hear me? Oh, that's pretty loud. Hello, is that good enough still? Hello, is that fine? Okay. Okay, so we have pharmacy students here now, right? Okay, I'm gonna just sit. I've been standing and walking and all this stuff, and my knee is a little sore, so I'm gonna just sit for a while. Hopefully it'll be fine. Before I go through the slide set, I want to talk a little bit about the differences of pharmacy practice in the U.S. in terms of a couple things, and also our education. So starting with the education, you know what? Actually, never mind. I'm going to go through the slides. I'll fill in the gaps on what I have, because I don't even remember what I have in here. I might have some of this stuff in here. Okay, so so this is a sample set, actually, of the type of PowerPoint slides that we use to teach students. And this is among any pharmacy program. We always have learning objectives on the slide, that by the end of the presentation, you should be able to do whatever or learn, know whatever. We also always have active words there because we want you to be able to do stuff. So those are the slides. So the focus of the pharmacy program, actually now I think I don't have it on the slide, so I will talk about it. So we used to have a B-Pharm and a PharmD program in the United States. Back in 2000, we got rid of the B-Pharm program to practice as a pharmacist in a community pharmacy, hospital, or any other role where you're interacting directly with patients. You must have a doctor of pharmacy degree. All of the students who entered in 2000 or later are graduating with a doctor of pharmacy or PharmD degree. It is, most of the time, your education ends up being 6 years to get to that point. However, you don't have to have all of that 6 years in an actual pharmacy program. So the Binghamton University Pharmacy Program is a 4-year graduate program, but you have to have at least 2 years of a bachelor program with all the prerequisite courses before you can come to our graduate program. And you can get the PharmD without having an undergrad. In our program, we have about 50% of our students do a full bachelor's degree, usually over 4 years' time, although some people do accelerated bachelor's for 3 years' time. But we have about half the class students do a bachelor's in biology, biochem, or chemistry, and then enter pharmacy for another 4 years. Or the other 50% do 2 years of prerequisites, and the prerequisites for pharmacy are basically everything you learn in your first year and in some of the stuff in your second year, minus the pharmaceutical emphasis. So if it says pharmaceutical organic chemistry, they are taking regular organic chemistry. We put the pharmaceutical slant on it and that thing when you come to the curriculum. So our prerequisites for pharmacy, in order even to start our PharmD program, are microbiology, 2 semesters of organic chemistry, 2 semesters inorganic, 2 semesters of biology, a statistics course, not biostats, although we will accept biostats, but a regular basic statistical course. You need to have communication courses. Our school usually, I mean, in the US, most people get that communication through an English course, but if you have a communication course, that's fine. It has to be written communication as well as oral communication. You also need a social science course at a bachelor's level. So you need to have something like psychology or sociology. Now, when we've done agreements and arrangements, which we call articulation, signed contract kind of things between international schools and us, we usually look at that curriculum, the undergrad curriculum, and try to identify some course that we would take for that social science, because you are not going to have a psychology course on your transcript or a sociology course. So I look at it and I will choose something else that is acceptable. If you're coming with a full bachelor's degree here, like a B Pharm, that'll be no problem. You'll definitely have everything you need for prereq. It's only if you're going to try to come to us after only having a couple years of your B Pharm, because your statistical course may be in your last year. However, you need that stats course to come to Binghamton, and that is an absolute must on the prerequisites. So either if you know that you're interested in the PharmD, you can either see if you can get permission to go to the biostats course early, or take a statistical course through a different department. You'll have to work that out with your faculty here. So anyway, so we're all PharmD now, and even before we were PharmD, the B Pharm was a 5-year bachelor's program. We've never had, at least not in modern times, a 4-year B Pharm program. It was always 5 years. So the PharmD program currently is a clinical program. It's to teach students how to care for patients and impact their positive health. So the things that we do not cover in our program that you may be exposed to in yours is there's no veterinary science, veterinary medicine. There is no cosmetics. We don't do pesticides. Drug supply chain management is very, very tiny in our program. It's really mostly geared to prerequisites. I mean, the early courses in the first year are set up to do clinical-based teaching. And then, like you guys are going out to hospitals in your latter years just for very brief experiences. But think about it as our final year pharmacy school, the 6th year, is an entire year of clinical experiences. You do take 2 online courses during that year because everybody goes all over the place for their clinical experiences. So we have online courses, but those online courses aren't pharmacy focused, they're professional development focused. And they are about training you about interview process, CV development, mock interviews, cover letters, how to ask for letters of recommendation. We have assignments with all of these that you have to have a CV, we give you feedback. So, and all of these things in those courses are giving you an advantage when you're going to get post-grad opportunities or even just get a job after graduation. So we do that in the last year. But during that last year, you're gonna spend full-time work and you're gonna pay for that. You still have to pay tuition for that. And you're gonna be at your hospital practice site and you're gonna get to go to 7 different places, and you're there for 6 weeks, at least 40 hours a week. But that's 40 hours a week, which is our normal US workday. But then you go home and you're gonna have to study every evening. So it is a very intense year. However, you're not sitting in seats. You're active, you're doing stuff, you're using the knowledge that you've learned all throughout. So you're professionally dressed all the time. We don't require professional dress for all of our regular courses, just for a couple of them. So pharmaceutical care is the basis by which our training is built upon. We are training pharmacists to provide care to the patient alongside other healthcare professionals for the purpose of curing a disease, eliminating or reducing the patient's symptoms, slowing the disease process or stopping it altogether, preventing disease. So preventing disease, which is why one of the examples is immunizations. Immunizations and vaccines run out of, lots of people get them from the pharmacy. Sometimes you can't get pediatric vaccines to the pharmacy, but there are states that vaccinate even children. But definitely all your adult vaccinations, and we in the United States encourage a lot of vaccinations. We have all throughout your life, you're getting vaccinations, and now pharmacists do it, so we train for that in our program. Helping the patient to receive the right medicine. So think about your pharmacy. If you have a cough, or let's say you think you have a bacterial infection, let's use skin infection, okay? Do you have to go to the doctor, or and if you're trained as a healthcare professional, right? You probably learned something about skin infections or microbiology of what that's likely to be. If you think you have a staph infection, do you have to go to the doctor, or can you just go to the pharmacy and get medicine? You can go to the pharmacy, right? Even if you don't have a prescription, you could say, hey, I need some amoxicillin or something like that. This is what I want for my skin infection. Or you have malaria, or you have whatever it is, cough, whatever. You can go and ask for it, and you can get whatever you want. Even though technically that might be on a list of drugs that the government or your pharmaceutical society, whatever that's called, says is on prescription, that's not really upheld. In the United States, though, everything that we say has to be on prescription cannot be dispensed, not only if it's not on a prescription from a provider, and most of those providers are doctors, but we also have what we call mid-level providers that are highly trained nurses, and then we have clinical officers or physician's assistants that are also trained to prescribe, so they can write the prescriptions. And everything is done electronically. It's all electronic medical records. So you're going to go to the doctor with that skin infection. They're going to prescribe something electronically. It's going to show up on the computer at the pharmacy, and the pharmacy technician or the pharmacist, it depends on how they run the pharmacy, is going to then reprofile that, re-enter that into the pharmacy system, and then they're going to dispense it. And if that pharmacist decides they need to go to the bathroom and you come in for that medicine, they are not going to give it to you. Even if it's been filled, it's checked, it's accurate, you are not going to get that medicine until that pharmacist comes back from the bathroom, back from lunch or whatever. It is not allowed to give out, dispense any medicine if the pharmacist isn't there, for the purpose of making sure they are there if patients have questions. And it's not only based on the patient questions, we tell people what they need to know, because some patients might think that they know what they need to know, but we want to assure that they know what they need to know. The other thing is, if you are, and let's just say you are in the pharmacy, and maybe you're working as a pharmacy intern or pharmacy tech, and you're giving out a medicine, or the pharmacist, so you've made sure that it's the right drug that the doctor wanted, it's the right dose the doctor wanted, the right labeling, if it's twice a day, it's done correctly. If it needs to be taken with food, that's added on the label. That's all correct. Does that ensure that the patient's hand infection, the skin infection gets better? No, there could be a lot of different things that go wrong in that scenario. The patient may not fully understand how to take the medicine, or they don't understand that the skin infection isn't going to go away tomorrow. You have to take it for many days, or maybe the skin infection does go away. They respond quickly and they say, oh, it's gone, or it's better, I don't need the antibiotic. But no, we know that in order to fully eradicate the microorganism, you need to take that prescription for 5 days probably, or 7 days, depending upon severity and things. So if they stop too early, the infection could come back, and that is a bad outcome. And then, of course, they've now been exposed to an antibiotic. So what does the organism do? It gets resistant. And so even if they resume therapy, it may not work. And if it doesn't work and there's rapid growth, they may go on to septicemia. And there's a high percentage of death when you have septicemia. So that is one situation where just doing what you thought was the right thing is not assuring the patient has a good outcome. They could be on drugs that interact. There's a lot of antibiotics that chelate with heavy metals like iron and magnesium and aluminum, and maybe they have stomach problems along with whatever's going on, and they've been like having a bunch of antacid, and they've taken the antibiotic correctly, but it's not even getting absorbed. They may not have the right outcome. In fact, they could end up dying because you did not confirm that there was no interacting drugs. And the doctors don't know about this. And in your setting, especially because you don't have people attending only one pharmacy, they may go to many, and I don't know if you have electronic records in the pharmacy, but in our pharmacy, so you probably heard of CVS Pharmacy in the United States, or Walmart or Walgreens. These are some of our big chain pharmacies. You could go to one in California, Hawaii, New York, and if it's the same CVS, they will be able to see your drugs. They'll know everything about you because it's all connected. Now, if you go to CVS one time and then you go to Walmart, they're not going to know the difference. They're not going to know, but they will within the same system. But of course, they're only going to know the things that you prescribe from the pharmacy. If you go up to the counter to pick up your prescription, but you also bring a bottle of calcium antacid or magnesium or whatever, that doesn't get profiled in the system. So nobody knows you're taking that. Or if you go to a dentist and you have something else, that might not go in there either. So there could be other drugs that interact. And if you don't ask the right questions of the patient to find that out, because in your setting, it would be very critical that you ask the right questions about prescription medicines, because you're not, I mean, if you don't have the electronic records in the pharmacy, and if they do go to many other pharmacies, you're not going to know just by pulling that up. And of course, no one's going to know if they're buying it cash and it's not in a computer system. So I'm trying to get across the fact that a pharmacist's role goes beyond making sure the drug is correct. Yes, that's extremely important, but it doesn't ensure the patient has a good health outcome. And that's what pharmaceutical care, that's the crux of what it's about. And we're going to talk about some more specific examples. So the role is beyond the pharmacy. And we have a duty to our patients. In fact, our pharmacy students take an oath. When they start pharmacy school, we have a big ceremony that we call the white coat ceremony, and it is very nice, and there's candle lighting, and there's music and pomp and circumstance, and the students are given white coats with their proper name badges on that they will be using, and they're short white coats because they're training. You're not allowed to wear the long white coat until you've graduated and you're an actual, you pass your licensure exams and you're a regular pharmacist. And that oath talks about that you're going to help the patient have good outcomes, that you're going to maintain confidentiality. You're not going to go home after your clinical rotation and say, oh, I had the most interesting patient today. They had this car accident and this is what happened and whatever, or gosh, they weren't taking their meds at all. And you're not going to talk about that with your friends. It is confidential. It's a need to know basis. In fact, actually, when our students do their SOAP notes, in case presentations, they need to make sure they take all identifiers out of it. They're not going to say the patient's name. And even on your computer, you are not supposed to have stuff on your computer that has patient names. So you have to take your notes about the patient with some kind of abbreviations, some kind of code that, to keep it straight in your own head, because you might be seeing 15 patients in one day. You need to be able to know one from another. But if your computer was stolen, we have to make sure that nobody has access to that information. And sometimes, that's out of your control. Someone breaks into your car, your computer was in there. Now patient information is potentially out there. And you actually have to sign documents that state that I pledge I'm not going to do this. So we have a lot of regulations, but it's all for the care of the patient. So it also goes beyond prescription medicines. Anything that the patient is taking, we want, pharmacists are the medication experts. We want to make sure patients are using it correctly. So even over-the-counter things, you should be educating about. So when people come and want to know something want something for cough, you don't just say, here's a cough syrup, but you make sure that it's the right one. In fact, I often give a scenario to the students. Person comes up to the counter, and at the very end, I'm going to kind of show you a slide with some of this information on it. Comes to the counter and says, I need something for a cough. And, you know, the pharmacist goes ahead and does a systematic process to ask them the right questions. That's what I'm going to show you later. We call it Scholar Mac. I'll explain that later. But anyway, you ask the right questions. You do what you're supposed to do, what we trained you to do. And you might even say, let me take you to the aisle where that is. And in American pharmacies, and I haven't been in a community pharmacy here yet, so I don't know if you have it just out in the aisle, but we have all of our over-the-counters, most of them. There are some that are stored behind the counter and you need to ask a pharmacist for, but mostly patients can come in and out of a pharmacy and never see a pharmacist. But if someone, and so in those cases, we don't even know that they're buying anything, so we can't interact on that. But once they come to you for advice, you now have a responsibility for the outcome of that patient. And I mean, it's a professional responsibility in that we care about our patients. We want them not to have side effects. We want them to get a good outcome. But it's also a legal issue. If a patient comes in, you told them to get something and they were harmed by it, and it turns out that you neglected to find out a piece of information that was critical and they had harm, you could be legally held liable. And so it's a very high level of responsibility that American trained pharmacists and practicing pharmacists have. So back to my example. So you're the diligent pharmacy student. You really want to make sure you're doing the process right. You get all the right questions. You say, you go the extra mile. I'll even show you where the cough products are. I'm going to go to the aisle and I'm going to tell you, obviously there's a lot of combination products. You know, if they say it's a cough at night, so maybe you have, you know, the product that has, you know, will help them with their sleep as well. You know, take this, there's a product we have called NyQuil. I don't know if that's a brand name you have here, but it has a lot of alcohol in it. Of course, cough products often have a lot of sugar in there. It has some, you know, antihistamines and things like that. Well, and you say this is the product and you give it to them. They leave. And what happened is you didn't ask, and then you miss one piece of information, that it was actually for their small child and not for them. And so now the person goes home and thinks that, oh, well, I can give this to my baby and maybe it's harmful for the baby. Or maybe that you forgot to ask about their diabetes. You forgot to ask if they had any other problems. And now their blood sugar goes out of control and they go into hyperglycemia because you gave them a high concentrated sugar syrup instead of the diabetic syrup. We also work with the healthcare team to make sure the doctors are prescribing the right drugs. So there are some drugs that pharmacists don't usually make the decisions about unless you're in the hospital working and rounding, then I do make recommendations. But if the patient just went to a clinic and I wasn't in the clinic, I can't really control what the doctor prescribes. But you still need to think, given what this patient has told me, given all their other meds, is this really the best thing for them? Because as a pharmacist, you know about a lot of other patient factors. Also, adverse drug events, most of them are predictable, and you can, by using food with it or taking it at bedtime, like maybe someone's starting new blood pressure, hypertension medicine. And you might want to tell them to take it at night, just in case their blood pressure drops, they'll be lying down and it'll be fine. If you don't tell them that, they take it in the morning and then they fall down and break their hip, that is a seriously bad outcome. And that could have been prevented because you didn't, if you would have given the right information. So these are like those, the way, you know, before the PharmD program, and even sometimes the older pharmacists today, this is what the role was. Let's get the right thing to the patient. But now we are going many steps beyond that. And fortunately, over many, many years, U.S. healthcare providers have been trained and working with pharmacists. So we are in a situation where doctors coming out of medical school, not all of them, I mean, there's still plenty of docs out there that don't really understand how much pharmacists can really participate in the healthcare of the patient. And we still have to advocate for ourselves and gently and carefully help them to understand what we can do. But it's a lot easier now. They even come out and they'll, you know, I mean, they're graduating, they're now practicing physicians. They even ask for pharmacists. Like, I want a pharmacist on my team. I don't want to, you know, I went to medical school in a academic medical center where we had nursing and pharmacy, and they always were on rounds with me, and also the case manager. So case manager, I don't know if you have that role here, that's a social worker that helps with the social economic stuff of the patient. Do you guys know the social determinants of health? Is that something you learn? But social determinants of health is all those other factors that need to be satisfied for a person to be healthy. So you could have, let's say you do your job, they have the right drug, they know how to take it, but if they can't afford it, they can't take, they only buy half of it because they can't afford it. Or, but let's say they have the drug, because we also have health insurance, but they live in squalor, they're homeless. Like they don't tell you they're embarrassed, they don't tell you they're homeless. They're not going to be set up to have the best outcomes. So anyway, we teach our students about that, and case managers help to make sure the patient, especially those with very serious illnesses that have been treated in the hospital, before they go, case managers, social workers meet with the patient and make sure they have the financial ability to get their meds. We don't want to make sure that they're fine in the hospital to have them go home with their new diagnosis of diabetes and find out that they're not going to be able to take those medicines and end up right back in the hospital. So social workers round with us, but physicians will say, I'm not rounding if I don't have pharmacists with me, if I don't have the case manager. And sometimes, they don't say it like that, but they really want the interdisciplinary approach. This is just, I already went through that. Okay, so, and I also already went through this. There's a lot of things pharmacists do that are very important, even in clinical pharmacy. So clinical pharmacists are trained in pharmaceutical care is direct patient care. Clinical pharmacist has that training for direct patient care, but they also do other things like drug formulary management. So helping a hospital or health insurance company know, does this drug, should I pay for this drug for a patient? Is this drug as good as the cheaper drug? And sometimes it's not. So when health insurance will say, no, I'm not paying for that, it's actually no better than the old drug. So clinical pharmacists do that. Clinical pharmacists write protocols and policies that the docs have to follow when they prescribe meds. In fact, a lot of our electronic medical records are so sophisticated, they have decision trees built in there where they will have to not state the diet. So they'll pull up the patient and they'll have to, they want a drug, an antibiotic, for example. They have to actually put in the diagnosis code. And if the diagnosis code doesn't match that antibiotic, like that antibiotic isn't used for that type of infection, the computer system will say, sorry, you can't use that medicine. And there may be some, or the dose, it'll double check the dose. Like they may write, maybe it's supposed to be for 20 milligrams and accidentally they say 2.0 instead of 20, and it'll say that's the wrong dose. And if the computer system doesn't do that from the decision tree within it for the physicians, the pharmacy will then get involved with that as well. They are, every time you fill a medicine, you have to look for these small, tiny things. This is just a bunch of other things that I put on here. Okay, so now I wanted to tell you about some of the research that has been done to prove the value added by clinical pharmacists. Some of this research is fairly old because we're pretty fortunately well accepted, although we still are all the time trying to initiate new things, new ways we can help patients. And every single time we want to do something more, expanding our scope of, that's called expanding our scope of practice. So for example, the immunization campaigns, we do that. And COVID, I'll tell you, COVID did a lot of bad things, but in the way of immunizations, that was a good thing because there were so many people sick. Our government had to give special authority to pharmacists to now vaccinate with COVID vaccines and other vaccines and even lower the age that we could do pediatrics. And they found out that with the research that there weren't side effects, more people were getting covered with vaccinations. So yes, now you can continue to do it. But that was what's called an expanded scope of practice. So every time we want to do expanded scope of practice, we have to prove our worth. So one study in Minnesota showed that 92% of the patients who were diabetic that were seen by a clinic pharmacist rather than the doctor were actually doing their blood glucose. So we have health insurance for a lot of patients, and it'll pay for the blood glucose monitor, and it'll pay for the strips, and stuff like that. So it's just getting the patient to do it. But a lot of patients don't want to do it. Who wants to stick their finger 4 times a day, or sometimes even more than that? But a pharmacist has the opportunity to take time and really help the patient to understand why this is important. If the doctor and the doctors usually spend 15 minutes with the patient, that's not enough time to help a patient understand why this is really needed. And so they often refer patients to pharmacists that will help them understand that it's needed, because we're going to adjust the dose of your insulin based on that. And we might give them a chart. If the blood glucose is this when you test it, this is the dose of insulin you get. And then if it goes too low, this is what you do. If it goes too high, this is what you do. Only 10% of the patients in the study were checking their blood glucose as compared to the pharmacists seeing patients. Anticoagulation is another super big area where pharmacists can help. Warfarin and vitamin K antagonists, you need to monitor that. And I know in some countries, and my work in Uganda, I found out that they don't have the ability to test the prothrombin time. In some, in some private hospitals, they do check INRs. But even if the person comes to the city, goes to a private hospital, they dose the warfarin per the INR, the PT-INR. If they go back to their remote village and they don't have an ability to go get their INR tested every month, they could bleed. And if you get too much warfarin and you bleed, you can die, you can have a stroke. The same way, if you get too little in your body, you can have a clot or stroke or whatever it is that you're preventing with the anticoagulation. So 89% of patients monitored by pharmacists are controlled versus only 50% done by the doctors. And so most medical doctors, this is one role that they've gladly given to pharmacists. They don't really want to touch anticoagulation at all because the risks are too great. Patients can die and have bleeds if it's not right. So Asheville project in North Carolina was the North Carolina Pharmacy School and Medical School all got together years and years ago, and they actually decided to have a full community health project where they engaged in improving the health of this rural area. And when pharmacists got involved, they had patients that weren't able to control their A1C level. For you guys know these labs, right, that I'm telling you about, or maybe some of the younger, earlier students don't, but you'll learn them. But A8 is not well controlled, and you can still have some of the bad diabetic complications like neuropathy and foot infections. And you've probably seen patients or heard of one that have to have their legs amputated because their blood sugar wasn't under control, or they lose their eyesight. And these things are things that cost people their livelihood. It's not just like, oh, you can't see now, or oh, you have to have a prosthetic or not have a prosthetic, but they now can't support their families. And we as pharmacists can play a role in that. HIV viral suppression, way higher percent of controlled patients when they're working with the pharmacist versus just working with doctors. In Brazil, this is a cost effectiveness study. Actually, I might not, there's cost effectiveness benefit analysis. I'm not sure if I have I don't know if that word is right, but anyway, it was looking at the cost of the cost savings. And that's another thing that you can do to help hospitals or even business owners of pharmacies. Well, not really, this is not for community, for hospitals, they only have so much money to pay for drugs. Well, if pharmacists are helping the patients get on the right antibiotic that is less expensive, they can save a lot of money, as you can see up there. So when no pharmacist was involved, $18,000 was the median cost or mean antibiotic cost per patient. When pharmacists were involved, it was in half. So that is going to endear you to the hospital administrators, right? They always want to save money. And if you can use the antibiotics wisely, you not only prevent antimicrobial resistance, and you still have a good outcome for the patient, but you save them money. In Taiwan, they did this study. IV to PO is a very common, what I call easy intervention to do. That's just saying, like, and you as pharmacists know how well a drug is absorbed orally versus IV. And if you have a drug like the class of fluoroquinoline, ciprofloxacin, levofloxacin, those are highly well absorbed orally. But if someone comes in and they're super, super sick, or they can't take anything by mouth, we give it to them IV, but it's way expensive IV. And we can give them oral doses and achieve the blood levels that you can get from IV. So as soon as they can eat, their stomach is now working, their GI tract works, we switch into PO and we save money. Discharge programs. So Patient comes in, maybe they have a few medicines from home, maybe they have heart disease, they come in because they have a myocardial infarction, and now they're on a lot more medicines, and maybe they change them up a bit. We have pharmacists involved with the discharge planning of that patient to make sure the patient knows what meds do I stop, what meds do I start. We even have pharmacists that actually will call the community pharmacy where they're going to make sure the records are adjusted in the community pharmacy. Because you could tell a patient and they can forget. I mean, I checked into the hotel yesterday and they told me, if you need this, dial this number. If you need this, dial that number. This is where you go for breakfast. You know, and I'm checking in, I'm, you know, tired from the day, and I'm like, I needed something last night. And it's like, I looked at the phone, I'm like, what did they say to call? I mean, that's like what patients do. You think you're giving them really good information, but they're overwhelmed with their scenario. We have to tell them over and over again. That's about them. And that process is called med reconciliation, making sure that all the medicines are appropriate through all levels of care. And of course, we do caregiver information. You know, going back to those social determinants of health, we need to find out, do you have health insurance? Do you have enough money to pay for this drug? There are many, many drugs available. There are low-cost drugs, there's high-cost drugs. Docs like to prescribe what they know has worked for them in the past. Or we have pharmaceutical care reps that go to the doctor's offices and say, this drug is better than that drug. But if you're a pharmacist and you know literature evaluation skills and you can read the studies, you know, you might not be able to rely on what the pharmaceutical care rep says, because what do they want to do? They want to sell drug, right? But maybe there's a tad better difference, but the difference might not be clinically significant. When do I need to stop? Okay, good. Remember I said that there was a systematic way, that a process by which we teach people to interact with patients. At Binghamton, we call it Scholar Mac, and this is an evidence-based approach that is in the literature. And I have something that I'll show you at the end about that. But it makes sure we teach them this process so that they don't forget anything, that they make sure they went through every step that they need to go to recommend the most appropriate treatment for the patient. We use it mostly for self-care issues, when patients come to the pharmacy and say, I have this problem, what should I use? But you can also use those same concepts if you're in the hospital and talking to patients and trying to figure out what's the best therapy for them. We evaluate renal and hepatic function. You know that drugs are eliminated from the body and they're metabolized, well, eliminated by the renal system mostly maybe after metabolism, or changed into inactive drugs, but actually prodrugs are changed into active drugs right by the liver. And so if the liver isn't functioning, let's say the person has very serious hepatitis, or maybe they have end-stage cirrhosis, and you know, we can't give them a prodrug. They're not going to convert that drug to the active component. Or if we give them certain active drugs that are highly extracted to detoxify the drug in the liver, and they don't have that possibility, they're going to have toxicity. And there's less drugs to deal with the hepatic system, but there's what I call clinical calculations. So we have something called a Child-Pugh score, which helps us to score the level of liver failure. And we can ask, we look at their albumin level, we look at their bilirubin level, we look to see if they have, what level of encephalopathy do they have? Do they have ascites, mild, moderate, severe? What is their anticoagulation status, their prothrombin time? Do they have enough liver function to make platelets? To make clotting factors. And if they are, it goes by a rating A, B, C, A being mild, C being severe. If they have a rating of C and they're on a drug that needs to go through the liver, we have to intervene because they're not going to be able to handle that drug. More often, it's the renal system that we're looking at. So we teach the students the creatinine clearance calculation formula. And they know that. It's like in a hospitalized setting, it's one of the first things we do. You always evaluate the renal function. In the hospital setting in the United States, coming in for infections is one of the highest diagnoses. Antibiotics have a very high level of being eliminated renally. So we always do that, and then we adjust the dose. But it's not just that first dose adjustment. So the patient comes in, they have pneumonia, and their body is so sick that they have sepsis, and it's affected their kidneys, and they have acute renal failure. So their creatinine is high. We calculate their clearance, their GFR, and it's very low. And so the doctor writes for medicine that is cleared renally. We look up our guidelines. Our students have access to lots of drug resources. We usually actually have them on our phones. Through our university, you have access for free to that. And you can look it up on your phone, and then you make a recommendation. Maybe they wrote for 500 milligrams a day, but for this level of renal function, it really should be 500 every other day to allow the kidneys time to eliminate the drug. But you can't just stop there, because in a couple days, when the patient's hydrated and the antibiotic is working, their kidney function is going to bounce back. And when it bounces back, they are now going to eliminate that drug faster, and their concentrations of antibiotics are going to be decreased. And when they're decreased, they may not be healed from their infection. So you as a pharmacist can't do this. It's not a once and done. Like, okay, I helped that patient, I'm going on my way. You need to follow them every single day and look at their kidney function. And as soon as it starts to turn around, you change you make a recommendation to the doctor. And actually, the renal dose adjustment is something that most hospitals allow pharmacists to do without a doctor even saying anything about it. They have written protocols, and they recognize that as a really solid role for a pharmacist. And of course, you might not be working 24/7, right? So you have to develop a communication method between you and any other pharmacists that are going to cover that patient when you're not there. At one of the old hospitals I worked at before I even went into academia, and this was before we had really good online systems where we could document that, we actually had binders. Every unit, the pharmacist on the unit had a binder. And every day, whenever we did these dose adjustments, we would write it in the binder, bed, room 300, the bed at the window, this is what I did for them. And when the next day the pharmacist that's scheduled there comes in, they open up the binder and say, who do I need to check on to make sure they're still doing okay? That way you have continuous quality care to the patient. Duplicate therapy. A lot of times doctors do double anaerobic therapy. So they might give metronidazole, but then they're also giving piperacillin and tazobactam. That's double anaerobic therapy, and in almost all cases, you do not need that. So that's a really quick intervention, and a lot of times docs don't really realize that. So, or maybe they're on, so back to formularies. A formulary is kind of like an essential medication list. It's the list of drugs that are stocked by the hospitals, and that formulary may change depending upon the buying group. Hospitals are in buying groups, and the pharmaceutical manufacturers makes deals with these buying groups, and every year or couple years they change the contracts and take the drug class of statin drugs for cholesterol, or proton pump inhibitors for stomach acid. There's many of them, right? They all are equally effective as long as the dose is appropriate. Some you need a lower dose because they're high potency, some you need a higher dose. But if you give the equivalent dose, it'll be the same. So a person comes in on one proton pump inhibitor, but that's not on the hospital formulary. The pharmacist goes to their protocol and says, oh, well, we have this different one. We're going to substitute that. But the pharmacist needs to make sure they interact with the patient so that when the patient is discharged, they know, and also with the physician, so that they don't write a new order for the new proton pump inhibitor, because what ends up happening is they go home, they start their home medicines, they take the proton pump inhibitor from the hospital, and now we have duplicate therapy. And while that may not necessarily be harmful talking about proton pump inhibitors, it's just not necessary, and it's an additional cost to that patient and just to our health system in general. So that medication reconciliation that I talked about, that discharge planning, that's where we catch things like this. And then when they come into the hospital on admission, we catch it like that. Sometimes it can be harmful. You wouldn't, like if the statin class of drugs was the formulary interchange, that's what we call it, is interchanging one drug for another. Too much statin certainly can actually cause harm. So anyway, pharmacists really need to be involved in that. We talked about IVDPO already. Drug-drug interactions. Our computer systems, the electronic medical records, they have built-in drug interaction checkers. So that's really nice. The computer system will automatically alert you when you go to put a profile of medicine. Not only will you see a list of all the medicines, this is both in community and hospital, But as soon as that medicine is at least in the partial amount of being entered, it will then tell you, oh, there's an interaction with all of these things. But the interaction may or may not be clinically significant. So at that point, you as a pharmacist do need to discuss whether or not it's a clinically interactive. Okay. Okay, so you see those. I'm going to go quickly to this screen, and then I'm going to take questions about all this. So this is that Scholar MAC process I talked about. So the S stands for symptoms. So we ask, that cough comes in. Tell me about your cough. And we also use open-ended questions, which I think you're trained in. And at least in the beginning, you know, tell me what brought you to the hospital or the pharmacy today. You know, why did you come to see me today? And usually that can help them just open up, well, this is what I had 3 days ago, whatever. I got a cough. But if not, you ask them specific things. And it's not just the symptom of the cough, but what else do you have? Do you have fever? And as a trained healthcare provider, you should know as soon as they have a cough, you should be thinking a differential diagnosis. Well, what could a cough be? It could be bronchitis, which is viral. It could be pneumonia. It could be allergic. It could be tuberculosis. So it could be cancer. So there's all these things. So you need to think about, well, if it's any of those things, what other symptoms would they have? And you start asking questions about, is it productive or not? What time of day? How long has it lasted? Do you have a fever? Is it a high fever? Is it a low-grade fever? Do you have sweats at night? So therefore you differentiate, because sometimes the best thing to do is send them to the hospital. If a person comes in and they give you the right answers that align with tuberculosis, you want that person to get to the care they need. You do not want to have them be given something that they don't need. So anyway, characteristics, history is like, what have you done for it? When did it start? The aggravating and remitting factors, that's like asking them what makes it worse, and what makes it better. And what makes it better could be, what medicines have you used before? And if they use, like, maybe they saw a traditional healer, maybe they went to the herbalist. Sometimes when they come to a hospital, they are ashamed that they did that because they think that you don't want to know about that. So it's important to be able to respectfully ask a person about those things, because it can really impact what you do. A lot of patients present with partially treated malaria, and if you don't, and their smear will be negative, but if you don't know that they took some plant that is effective, but they just didn't have enough of it, or their body just it was worse, you know, you may misdiagnose them. So we want to know what they did before. MAC is, what other medicines are you on? That's how we make sure that we don't have drug interactions. Allergies, you know, any bad reactions to medicines. I don't want to give you something that you reacted badly to. Conditions. Do you have other chronic illnesses that are going to affect what I say about, like diabetic, that cough syrup thing? You got to find out if they have diabetes before you recommend a sugar cough syrup. And then these are just the questions you would ask. Okay, and that's, you'll get the slide set, you can review that. But some of these things, in order to do these higher levels of care, working directly on the patient rounds in the hospital, actually having authority to do the anticoagulation and stuff like that, you need postgraduate training. So residency is what we do for clinical training. Some people want to go into industry, so they do fellowships. But the industry stuff that PharmDs do is not research and development or analysis of drug. It's not bench research drug. It's more in the regulatory affairs division, clinical trial management. It might even be marketing. The FDA requires all marketing materials are approved by them. You might go to medical writing. I think there's time for 1 or 2 questions.
Good afternoon, ma'am. This is Manognya from second year. First of all, thank you very much for the presentation, ma'am. I would like to ask a question regarding what are the job opportunities in clinical trials?
Thank you. Great question. So most of the graduates from the PharmD program go into community pharmacy practice. And community pharmacy practice right now has become a very tough environment to work in. and people are leaving that sector because we're having a lot of other better jobs come up since COVID. The telehealth or telemedicine has become very popular. And so in a community pharmacy, there's hordes of patients, it's busy, there's lines, and Oh, telemedicine. So telemedicine is where you, there's a couple ways. Clinically, you can see a patient from your home. So my daughter-in-law, my oldest son, is married to a telemedicine pharmacist for the Veterans Administration, so military veterans through the government. She sits in her home office every day, but she sees patients independently. She has prescribing authority to treat diabetes, hypertension, heart disease, a whole host, even women's health issues. She sees the veterans via video conferencing, and sometimes it's just telephone because not everybody's able to do the video conferencing. She has access to online medical records, so she sees everything, blood pressures, lab tests, and it's a really nice environment because you're at home, you don't have to go anywhere, and it's pretty lucrative. You make a pretty good living there. So the work environment is really good, and it's using your clinical skills. Community pharmacy, there's lots of job openings because people are transitioning to this telehealth. So yes, telehealth is like the newest thing, but because of that, there's a lot of openings in community pharmacy. So that if you want to make the most money right away through school without postgraduate training, you go to community pharmacy. And the entry-level salary for a PharmD graduate is, the average across the US is $136,000 per year, often accompanied by a bonus of $10,000 to $50,000 with a retention rate of like, you get $10,000 per year, you're retained there.
I think it's more than the software engineers, starting salaries or middle salaries.
Yeah. We also have people going to hospital pharmacy and hospital pharmacy practice. You can do like regular staffing things, which is managing the drug supply. So we have pharmacy technicians or even robotics that fill most of our prescriptions. Or sometimes we have these dispensing machines. So it's put in a computer. The technicians go fill these machines up. And when they get to the nurses get to the patient, they pull up the computer. They say, I want to give this lisinopril dose for this patient. And the machine automatically pops out a drawer where the only thing in it is lisinopril. So they don't mess up, they don't choose the wrong drug. They give it to them. So we have pharmacists that supervise that whole process. But then the clinical stuff that I was talking about, that usually requires the post-grad training of at least 1 year of residency. Any other questions?
Good afternoon, ma'am.
Yeah.
How much priority are master students given when compared to the PharmD students regarding the residency? Are we going to get the same priority and the amount of work when compared to the PharmD students?
So in the United States, you have to be able to be licensed pharmacist in the United States to qualify for residency. And we do not have clinical master's programs in the United States. So master's students don't qualify for residency. You have to have a PharmD. And unfortunately, internationally trained B Pharms cannot qualify for residency or being a pharmacist in the US. Since the PharmD program, they've eliminated the ability for you to take the foreign graduate equivalency again and do it. So the path for a B Pharm international training is that you have to come and do a PharmD. In the US, if you want to be a practicing US pharmacist, and if you want to do residency, you then do as best you can in that program, and then you qualify. And we do have international students successfully get residency in the US and even second year specialty residency. We currently have 2 Canadian students that are in their second year specialty residency, even though they don't get OPD for that. So the places where they are, once they got through their first year, they are sponsoring their visas. It is definitely possible. Masters. If you have a master's of clinical pharmacy, which is a 5-year degree or more, you do qualify to apply for the foreign graduate equivalency exam. So you need to have at least 5 years of a clinical master's to do that. And you have to score high enough on that exam. Actually, I think it's just pass fail. So you have to pass that exam. And once you do it, then you can investigate each state requirements for being a pharmacist. But it always includes internship, which means that you have to get a job most of the time in a community pharmacy, because that's where they need people the most. You have to work for 9 months to a year, not as a pharmacist, but working under a pharmacist. You will get paid a sufficient salary for living and things. It's very low, but it's much higher probably than here. And as long as you're rooming with roommates and stuff and you're living meagerly, you'll be fine. The problem is trying to get those jobs, because at the technician level, intern level, not a lot of pharmacies will hire you. Pharmacists, they will sponsor visa for pharmacists once you're here. But again, if you're competing against people that don't need a visa, you have to be super good to compete with them. But there is a path. It's just long and expensive because you have to come to the States, you have to pass that foreign graduate equivalency. You take your internship for a year, and then, and only then, do you qualify to take a licensure exam, which is called the NAPLEX, which is a very hard exam for which you may not be fully prepared in your clinical pharmacy master's. So we do have training materials that are available. They're just like $1,000. So that's another expense. You get the training materials, you study it over the year, you take that exam. You also have to take law exam. Everyone in the United States has to take a pharmacy law exam too. Once you do all that, you are a pharmacist in that state, and now you qualify to apply for any pharmacist job and residency.
Ma'am, if we had to deviate from clinical pharmacy and enter into subjects like health informatics and all, what is your take on that?
Okay, that's a good question. So there is a path to do pharmacy work that's not industry and not clinical pharmacy, but in the realm of health outcomes or hospital management, healthcare management. There's definitely avenues for you to do that. Those do not require a pharmacy license. So we have PhDs in those programs. We have masters in those programs. We don't have it at Binghamton, but there are in the United States. And I don't know where they are, but I know that there are international students successfully have done that. I would just say Google for it and look for masters of healthcare, hospital pharmacy. You could get masters of hospital pharmacy, that kind of thing, to find those programs. Yep. And actually, if you did that in the U.S. and you were then becoming you'd be residential in the U.S. with doing that program, you might actually, if you still wanted to do clinical work, if that was really your end goal, that would probably get you a spot more. Someone would hire you more because you would already have said, I'm dedicated to being here. I've done this extra program. You would also be able to go to those pharmacies and meet people, talk with them. You could even get a job in a pharmacy just as a cashier, like part-time. And then you talk to the pharmacist and the pharmacy manager, and they know you. And then when they have an opening, that you get that opening. So that's actually a really good idea.
Yeah, thank you. One last question, ma'am. I would like to hear you. This is regarding the INR, abnormal INR value. The patient is on therapy with warfarin. If he comes out, turn out to the clinic with abnormal INR, what are the points as a pharmacist you need to consider to extract what exactly the reason behind it?
So what would we do with the patient who has an elevated INR?
Yeah.
Okay, so an elevated INR, so the normal patient for anticoagulation.
Kindly elaborate what is INR and what is a normal value, then you can go to understand better.
So I was going to go there. So for anticoagulation for someone who had a pulmonary embolism, the normal goal, like a normal INR, is 1 or a little bit below 1. We want to prolong that, meaning it takes longer for the blood to clot so you don't get another pulmonary embolism, which is a clot in the pulmonary artery. So we want it to be prolonged at 2 to 3. That's the main thing we want. So if someone comes to clinic for their normal monthly check of their INR, and we actually, pharmacists do this by point of care testing. So they have a finger prick thing, the pharmacist in the clinic does it, and in seconds they know what the INR. So let's say the INR comes back at 6. Okay, that's quite high, right? But we can't just evaluate a number for a number. We have to find out, is it clinically important? We certainly don't want it to be 6, and we're going to take some measures so that number comes down, because the longer it's elevated, the more chance for the patient to bleed. It means their blood is very thin. If they get bruising, they cut themselves, it's going to take a lot longer. And the worst thing would be is if they fall and hit their head, they can have intracerebral bleeding, which can be deadly. So we ask questions about their clinical symptoms. Do they have any bleeding? Are you bleeding in your urine? Are you have any blood in your stools? We have to, and you can't just say, do you have blood in your stools or urine? Because they might think blood is red, right? Oh, my urine doesn't look red. My stools don't look red. No, I don't have blood in there. But you have to know that when blood is in your urine, it might not be red. It could be red. You could actually see little clots, but it could just be pink or just slightly off color. In the feces, it usually turns the feces black. So you have to teach them to look at it and ask, ask the right questions. You might you actually would ask them, do you have any unusual bruising? And in a clinic setting, you would look where we don't necessarily tell them to undress and stuff unless we see signs of problem. Like we might say, let's roll up your sleeves. I look for petechiae, which is tiny little dots of blood under the skin that can develop simultaneously. Look at their legs. Maybe you lift up their shirt. So we're not usually like putting them in a gown and stuff like that, but you can see enough that they have that and you can ask them about it. So if they don't have any bleeding issues, we would consider them stable. And the way we would manage that is by reducing the dose of warfarin. So the normal thing, so it takes warfarin, like for every dose change you make, it takes about 5 days to 7 days to see the full effect of that effect on the clotting cascade. And so we would probably and there are protocols for this, so pharmacists learn these protocols, but you would probably say to the patient, okay, it seems like you're stable, but these are the things I want you to look at, and if any of these things start to happen, you call me back right away or you go to the emergency room, like all those things I mentioned. But in lieu of that, if you're still fine, for the next 2 days, you don't take any Coumadin, any warfarin. And then the next day after that, you take half of your normal dose, for example. And you're going to take half your normal dose for the next 5 days. And then we're going to do another INR. You're going to come to the clinic or go to a local lab, and they're going to call me and see what that is. And we'll see if that was enough to reverse you. And then on a routine basis, we will reduce your dose. Now, we also have to ask about interactions, because they may have been on maybe the reason because we need to always investigate, well, why was the INR elevated? We can't just treat it as a lab or a result in and of itself. We want to know, well, why did this happen? We want to prevent it from happening again. So we have to see it, and sometimes you never figure it out. And so then you just treat it and you kind of be more closely watch the patient. But sometimes by asking the right questions, you figure it out. So maybe they had an infection, a community-acquired pneumonia that they didn't have to go to the hospital for, but they got put on an antibiotic that interferes with the metabolism of warfarin, like the cytochrome P450 enzymes, and maybe that is why they got elevated INR. Something like that. We try to figure out what it's about. Then, so the other scenario, so their INR is 6, it's elevated, but the patient has symptoms. Maybe they actually came to the hospital because they got cut. They were doing their cooking, they accidentally cut their arm, and now it's not stopping bleeding. And it's like bleeding all over the place, and they come to the hospital. So that is clinically important. Or maybe they just call you up because they wake up in the morning and their urine is like all really dark and it has blood clots in it. And so that's a clinical abnormality. So that's a bad thing. So that means that INR is clinically relevant. So now we need to take proactive reversal. So warfarin is vitamin K antagonist, so we can simply give vitamin K. But then, well, I say simply, but it's not simple. Vitamin K, what doctors used to do is they would give 10 milligrams of IV vitamin K. But if you do that, you will absolutely reverse that INR. But it will go down to 1, and now the patient is at risk for a clot. And remember, every time you meddle with the warfarin, it takes days and days to see the exact results. So you're going to be in this catch-22. It's too high, it's too low, risk for clot, risk for bleeding. So as a pharmacist, we know that depending upon how severe the clinical symptoms are, we give very small doses of vitamin K. Or sometimes we have to actually give platelets, or we have to give clotting factors, plasma, fresh frozen plasma, which that's actually the best thing to do. Of course, it's a human blood product, and not all people want human blood products. So sometimes we're not allowed to give that per the patient's wishes. But if you give fresh frozen plasma, which means giving the patient the clotting factors they need, they're going to work immediately. Immediately, that patient is going to stop bleeding because now they have the clotting factors. But we still have to modify the warfarin dose in the future, so we prevent the problem from happening.
Thank you, ma'am.
Thank you, ma'am, for your enlightening session. And usually my students will run away at 12:40, and they run faster than the rats in their stomach, but still you made them to stay and stay focused. And thank you for your enlightening session on the admission process schedule. You also focused on the career opportunities during and after MS as well as PhD program. And for faculty, you also focused on the research facilities available as well as the faculty who are involved in various disciplines of pharmaceutical care. I am personally connected to you when the talk was about the significance of pharmacist role. I wish to see the same in India sooner or later. And thank you, ma'am. Thank you for the knowledgeable session. And
can I say just one more thing? So remember when I was showing you about the data that showed the worth of the clinical pharmacist? As you guys go out and experience healthcare practice, and I know you guys are B-Pharm, so you're probably, most of you aren't probably interested really in this, but it's still helpful to know where you could improve. But these could be ideas, probably more for your PharmD students down in Bima Verum. But if you have to do some small research, those projects that I mentioned, those are easy to do. They're small little projects that could show that pharmacists have big impact.
thank you, ma'am. Thank you for the session. Now invite our principal sir to give away the memento as a token of appreciation.
Do you want me to move?
No, you can just stand up.
Right. I think thank you all for your patient listening, despite you have some examination. So once again, I wholeheartedly thank you for your gracious presence here, and the energies are really good. And we wish that they'll be, she'll be visiting us again. And I think people who are really interested in going abroad, right? You should start thinking and focusing now itself. And I should congratulate Dinesh and all their team. He is going to take care of the international educational programs. So you have any questions, please meet him and he will guide you for that, right? And I think pharmacy abroad is really very good, and you should start focusing right from day one, because overnight you cannot get good scores or admissions into good universities. And we are also looking for a program where discussions are on, where we can decrease the credits if you want to opt for Binghamton University. If you are a VIPER student, means like to tell you in a simple word, you have to pass say 5 examinations, 5 subjects. But if you are a VIPER student, you need to pass only 4 examinations. So one examination you can skip off. So we are looking for such way, right, where VIPER students get the advantage if they go for admission into Binghamton because of our MOU. So you will be saving each, say, examination fees will be around 4 to 5 lakhs, right? So that you will be waived. So you will get at a very cheaper cost, your study. Secondly, some of the tests you need not write if you go through our channel. So this is, of course, still it is in the nascent stage, but definitely you'll get an advantage. I hope you understood something, although you are not in final year, but still I think you will be learning it a lot. So I think with this, thank you one and all, and I wish all of you to aspire more. And there's a wonderful opportunities abroad. And I think as you were asking to answer the one of the question is, if you do an MS there, right, you can also work, if not as a full-time pharmacist or a pharmacy technician is a one where you will be also getting, yeah, that's a, yeah.
Yes, I forgot to mention that, but there is a program called CPD, which is curricular practical training. And as long as the program that you're in the US relates to the educational program that you're in the US, the F1 student visa will allow you to work off campus in a related field. It requires that it is attached to curriculum. I don't know how that would be done on the MS programs, but I can check on that. But for our PharmD program, we have developed a 0 credit, 0 fee course. So it doesn't cost you any more to enroll in the course, but you have to secure your job in the community pharmacy. And once you do that, we work with them, and you can work up to 20 hours a week, which is a lot. You probably wouldn't want to work that much while you're in your schooling, but you can work up to 40 hours a week in the break time.
Thank you. And I think
I request Namira to propose vote of thanks.
A very good afternoon to the respected dignitaries. What a glorious morning we had. Myself, Namira Jobin, Assistant Professor at VIPER. So it gives me immense pleasure to present vote of thanks of today's session. I present my deepest gratitude to Dr. Karen Beth Bohan, Professor at Binghamton University, for investing your valuable time at VIPER and enlightening us and giving us insights about Binghamton University. We appreciate your time, ma'am, and thanks a lot. It's a special thanks to Dr. Lakshmi Prasad, sir, Director BVRIT, and we are very grateful to our principal, Dr. A. Ramesh, who is always energetic and enthusiastic in conducting such great events. A special appreciation to the faculty of VIPER and BVRIT, and a very big consideration to our students who are patiently listening since morning. Thank you all. I thank Dr. Dinesh sir and Dr. Ahmadi Banu ma'am, for coordinator overseas study affairs, for giving me this opportunity. Thank you one and all.
Staff, all the staff can come forward on the stage to take the picture, group picture. Madam, stage fill. All the staff to come onto the dais for group picture quickly.